Welcome to the 2019 National Institutes of Health World AIDS Day observance. As a reminder to you, I want you to remember that this is being live streamed, so we're very excited about that. And I really would like to thank all of those who are here, who came in person, and those who are going to be viewing remotely. And I also want to acknowledge the team from the Office of AIDS Research who organized and implemented the program for today. I'm Maureen Goodnow, and I am the Director of the Office of AIDS Research at the NIH. The observance of World AIDS Day started in 1988 and has grown into an annual event observed across the globe, bringing attention to, awareness of, and knowledge about the HIV pandemic. Reminder about how far we have come. It's a remembrance of those we have lost, and a reinforcement of our commitment and resolve to end the pandemic. Biomedical research at the NIH over the last 30-plus years represents a significant investment by the U.S. public and has resulted in discoveries, products, and practices focused to end the HIV pandemic and improve health outcomes for people with, at risk for, or impacted by HIV. Research discoveries set the framework for public health and public policies to end the HIV epidemic. But robust community engagement is critical, and since the earliest days of the pandemic, community voices were raised and continue today as significant partners and as beacons in the research discovery. This year, there's a harmonization of the World AIDS Day themes. At the international level, UNAIDS theme is Communities Make the Difference. At the U.S. federal government theme is Ending the HIV/AIDS Epidemic, Community by Community. And the NIH observance theme is Community and NIH in Partnership to End the HIV Epidemic. Just as the demographics of the global epidemic have evolved in complexity and diversity, the community partners represent even more complex and diverse groups, as you'll see by our panelists today. But something in common is across the epidemic time span and populations is the persistent dedication, creativity, and resiliency of the communities. Their willingness to speak out about what works and what is needed to end the epidemic, to let us know when the research might be better aligned with priorities, and remind us that doing more of the same will not necessarily change outcomes. We are delighted today to have Dr. Francis Collins, the NIH Director, to open and set the stage for the event, and to hear from a cross-section of community partners, starting with reflections by Mrs. Jeanne White Ginder, followed by two panels, and finally an opportunity to hear from you. So don't leave before the end. And so now I would like to move ahead and introduce Dr. Francis Collins, a physician and geneticist known for his discoveries of human disease genes and his leadership on the hallmark Human Genome Sequencing Project. Prior to NIH, he was a Howard Hughes Medical Institute investigator at the University of Michigan, and then director of the National Human Genetics Research Institute here at the NIH. He was appointed the 16th director of the NIH by President Obama in 2009, and in 2017, President Trump announced his selection of Dr. Collins to continue serving as the NIH director. He is a staunch supporter of the NIH HIV/AIDS research agenda and is committed to improving the health of communities and people at risk for or affected by HIV. I'm really pleased to introduce and to present Dr. Francis Collins.
Thank you, Maureen, and good morning to all of you gathered here in Lipset and those who are watching by video link. This is my 11th year as NIH Director, so this is my 11th World AIDS Day in this role, and I always look forward to this as a time for us to reflect on what we have been through over the course of these 3 decades and what more we still have to do. And the theme of what we're here to talk about today, about community involvement, could not be more important than it is right now. We've made stunning progress, but we still have some distance to go. There are 700,000 Americans who've lost their lives since 1981 to HIV/AIDS. We memorialize them today, as we do in every World AIDS Day. Globally, 32 million individuals have died. But what was a death sentence in 1990 is no longer associated with such a hopeless outcome. There has been this stunning progress. For those who can access antiretroviral therapy, HIV is now a chronic disease associated with a nearly normal lifespan instead of a death sentence. But as I said, we still have a long way to go before we can declare victory. Globally, 38 million people are infected with HIV. Thanks to PEPFAR and the Global Fund and other efforts, a lot of those people are on treatment, about 15 million, but many are still not. And here in the U.S., about 1.1 million Americans are currently infected with HIV. About 14% of those, about 150,000, are unaware of their HIV-positive status. Another 250,000 have been diagnosed but are not effectively engaged in care. And so, sadly, transmission of the virus continues. Without additional intervention, the number of new cases each year, which has been just at about 40,000 for the past several years, will continue. So another 400,000 Americans over the next 10 years, unless our interventions can succeed. And that's where I think community groups are going to be absolutely critical. The President has announced an intention to reduce the number of new cases by 90% in the next 10 years. How are we going to get there? The government is spending $20 billion in annual direct health expenditures for HIV prevention and care. NIH dedicates $3 billion, slightly more than that, annually to research in this area. But ending the epidemic is going to take more than money. Community engagement is what's desperately needed to bring disproportionately burdened populations and persons into testing and treatment. Otherwise, we will not see the end of this epidemic. So what do we mean by community engagement? Well, almost everything that's represented by the folks who are here today. The continuum of outreach, of consultation, of involvement, of collaboration, of shared leadership. It has to go beyond physical involvement to generating ideas, contributing to decision-making, sharing responsibility. Communities touched by HIV play a key role in battling stigma, which is still a major barrier to many individuals finding out their status and getting into treatment. And that includes stigma of many sorts: gender inequality, homophobia, transphobia, etc. Communities are best positioned to address those barriers. Now, it's fair to say, I think community involvement has been critically involved in the progress we have made. Patient-driven clinical trial designs, going back many years, community advisory boards that continue to play a critical role in HIV research. But we're going to hear a lot more from today's panelists about community engagement and the role that these efforts have been playing. Now today, thanks to the hard work of many community members and the person who I'll introduce here in a moment, the federal Jeanne White HIV/AIDS program provides a comprehensive system of primary medical care, support services, and medications for low-income people living with HIV. More than half of Americans with HIV now receive services through Jeanne White. And that's translating 30 years of HIV research supported by NIH into better health. We are working hard at NIH to develop new approaches to HIV. Trials of 3 different vaccines are underway right now, 2 in South Africa, 1 in the Americas and in Europe. And we just announced a month ago a truly bold new collaboration with the Gates Foundation to develop a gene editing cure for HIV in 10 years, so that those individuals who currently have to take antiretrovirals for the entire duration of their life might have an opportunity in a one-time cure to be literally free of the virus. That is a very bold goal, but it seemed like it was time to see what we could do. But for right now, the vaccines haven't been proven. The cure is not at hand. The most important strategy is prevention. And with tools like PrEP, pre-exposure prophylaxis, and the U=U approach, that is testing and treating, since we know that unmeasurable levels of virus means that that person is no longer infectious. We have the means to end this epidemic in this country. It won't take more scientific breakthroughs to get there, but it won't happen without community partnership, and that's what we're here to highlight today. We know that the new cases are not evenly distributed across the country. More than 50% of those new cases occur in just 48 counties, plus Washington, D.C., plus San Juan. So we have the opportunity to focus our efforts in a way that will be even more successful. All of that puts us in a place, I think, right now to be both motivated and optimistic about what we could accomplish in the course of this decade as we aim to try to end this epidemic in the United States. And it could hardly be a better time or a more appropriate moment to hear from one of the legendary community leaders who got this ball rolling, and that is the mother of Ryan White, Jeanne White Ginder. Jeanne's story begins just before Christmas in 1984, when she learned that her son Ryan, a hemophiliac, had contracted AIDS from a tainted blood product. About 90% of hemophiliacs became HIV positive in that time when we had no means of testing the blood that they needed for their blood clotting problem. Doctors gave Ryan only 6 months to live, but he was determined to stay in school. And his efforts to remain as normal as possible, a kid who needed to get into school and to learn new things and to head off to a future, attracted the attention of the nation. Jeanne was determined to give him that dream, and that effort forever changed the view of AIDS and those living with it. Sadly, Ryan passed away in 1990, just 1 month prior to his high school graduation. But his memory lives on in very many positive ways. Of course, most people know his name because of the Ryan White HIV/AIDS program. His name is an invitation to experience life, a call for understanding, a cry for increased research, and a call for all communities to gather together to find ways to end this epidemic. As for Jeanne, she would say she certainly would not have chosen this particular life pathway. What mother would have had, if given the chance, the opportunity to avoid seeing a son affected in this way and then taken far too soon. But she has taken that adversity and turned it into a noble action on her part to become a tireless advocate for people with HIV, testifying in support of the Ryan White program, established just months after her son's death. And she continues to inspire people all over the world by sharing her story of one very brave boy, and I might add, one very courageous mom. So please join me now in giving Jeanne a warm welcome to NIH's observance of World AIDS Day.
My name is Jeanne White Ginder, and I'm the mother of Ryan White. And I also have a beautiful daughter, Andrea, who very much lived the story, but was often left out of the story because the focus was mostly on Ryan and I. I'm just a mom. I'm a mom just like you moms, and Ryan was a kid just like your kids, an everyday kid. But because of a misunderstood disease called AIDS, my life changed overnight. In 1984, my son Ryan White was diagnosed with AIDS. He was one of the first children and first hemophiliacs to come down with AIDS. It was a new disease. It was fatal. People were scared. There wasn't a lot of written material on AIDS. People were very misled. People believed that maybe kissing, tears, sweat, and saliva might spread AIDS. And we had people that were confused. They said, well, what about mosquitoes and fleas? Maybe our kids could get AIDS from Ryan, just by mosquitoes being infected. So it was a long educational process, I think, to try to educate the general public on this disease. Ryan was born with severe hemophilia. He was born with severe hemophilia that needed a blood clotting agent called factor VIII. The factor VIII we thought was a godsend. We thought that it was a miracle drug because it enabled our hemophiliacs to live almost a normal life. But instead we found out that this drug, the drug that we thought was saving their life, was going to be the drug that took most of their lives because it contained the HIV virus. What I knew about AIDS in 1984 was very little. I sure didn't think that I was going to have to worry about my son getting AIDS. In 1983, I remember seeing a gentleman on TV. He had weighed probably about 60 pounds and had just wasted away. I remember feeling so bad for him because he had no family, no support, and he had trouble even getting people to take care of him. But I never dreamed that I would see my son almost in the same predicament. Ryan was diagnosed with a T-cell count of 25, and they gave him 3 to 6 months to live. And I, as a strong Christian, I thought, there's somehow, some way this is going to be all wrong. I mean, I'm going to get a miracle, or they're going to be wrong about their diagnosis or something. Dr. Kleinman, a head of infectious disease at Riley, assured me that no, Ryan has AIDS. And I said, I want to know all there is to know about this disease. He said, well, there's not a lot of information out there. I said, as a mom, every cough, every fever, I'm going to worry about whether it's the last. I want to know what to look for to make sure my son don't get sick. He said, I'm going to give you the number. I know you're a strong Christian lady, but he said, I'm going to give you the number of the American Foundation for AIDS Research. And you can call them, you can, do what you want. I had absolutely nobody to talk to. Ryan being one of the first children in hemophiliacs, I had absolutely no one. So I called MFAR. It was the best thing I ever did in my life. On the other end of the line was a gentleman by the name of Terry Byrne, and Terry became my best friend in the whole world. He opened up the community to where I had not ever been involved with, the gay community, but it was a support team. It was everybody helping one another. I can remember the first ever AIDS benefit in New York, and Terry calls me, and we're being ridiculed in our home city. Ryan was fighting to go to school. It was really miserable because people were so afraid of how you could get AIDS and how this is God's punishment for people who do bad things. We heard it all. There's funny things going on in that household, and that's how that boy really got AIDS. And you'd try to explain to people that he got it from his factor used to treat his hemophilia, but people did not want to hear. People wanted this disease to not be anywhere. They wanted to just blame people. So I definitely saw how the gay community was being treated because we were being treated the same way. But we went to this event in New York, and the first ever AIDS benefit, and we were just so excited. We were so excited because it would show that you can't get AIDS by being next to somebody. Elizabeth Taylor had agreed to do this event, and all these celebrities were going to be there, and it showed that AIDS could not hop, skip, jump around like everybody thought it could. And so we went, and Ryan went on Good Morning America, and David Hartman asked him, he said, Ryan, who are you looking forward to meeting at this AIDS benefit? Ryan said, meeting Elton John, definitely. Well, I was a little shocked at that because I love Elton's music, but I thought Elton was a little weird. That's why you can never think that, people, because they may end up being your best friend in the whole world, which Elton eventually was, or is even still today. But Ryan come into the green room, and I said, why did you say Elton John? He said, because he's not afraid to be different. Out of the mouths of children, sometimes you hear a lot of things that really wakens you up to a whole different outlook on life. And because we were searching every day for a medicine, some kind of treatment or something, every day was a day that you'd read something in the newspaper, and then you try to follow through, and then there'd be another one, and nothing ever panned out. And I'd call Terry, and Terry would say, no. And finally, I got to get this call. You're so desperate for anything. Your child is finally living 6 months, and then 8 months, and he's living past the 3 to 6 months they had already given him. And you're just, every day, you're just wanting something, to hear something that is going to work and be successful. And then I get this call from Terry, and he said, is there any way you guys can come to New York? He said, we're at Roosevelt Memorial Hospital. We're having drug testing for a drug called PHA-23. It ended up not being a successful drug, but by golly, you're there. You were just, every little hope or link that you think that might be there, you're there. But we went to New York, and Ryan was sitting in the lab room getting his lab work drawn. And a gentleman came up to Ryan. He said, you're Ryan White, aren't you? Ryan said, yes. He said, our whole community is running so scared, and here you are reading a comic book. And Ryan said, yes. And he said, they found 12 tumors in me. He said, I haven't been diagnosed with AIDS yet, but they're pretty sure that's what I have. He said, I want to thank you for all you've done for people with AIDS. The gentleman turned around and walked away, and Ryan said, you know, Mom, I'm the only one that knows what he's going through. He said, we're both fighting this same disease. Ryan says, you know, Mom, once you have AIDS, you're just like everybody else who has AIDS. You're fighting to stay alive. He goes, I want to educate everybody about this disease. I want this to be a disease and not a dirty word. I tell you, I saw a kid grow up. He wanted to go to school. He wanted to just be like everybody else. I remember him calling at me at work and telling me how bored he was, sitting at home. It was almost like every night when I went home, it was like he was waiting to die. He was waiting to get sick. And finally he said, Mom, I want to go back to school. Will you call the school and see if I can visit? He said, they have pizza on Friday, and I really like the school's pizza. He said, maybe if I just saw some of my friends, I'd be okay. Well, it ended up, we did a court battle. The school said no, he could not come back to school. So for a year and a half, we fought the public school system. And Ryan, the more they fought, the more popular Ryan became, because he took on the challenge of educating everybody about AIDS. He testified before the Presidential AIDS Commission. He spoke on the Phil Donahue show. He did all these news related. The media loved Ryan, and you don't hear that a lot about the media these days, but the media was Ryan's educators. They helped him to educate the general public. I can remember the decision to finally move came about because of a made-for-TV movie. Ryan finally won the right to go back to school, but the prejudice was still there. He had handled himself so well in front of the media, but I get a call at work, and Ryan says, Mom, I'm not sure what to do. I said, what's the matter? He said, well, when I got to school, the outside of my folders were marked fag and other thing. Somebody's been in my locker, my books and everything has got magic marker, things wrote on them. He says, I can't take these things to class so everybody will laugh. I said, Ryan, give me the principal. He said, Mommy's not here. I ended up talking to a secretary, and I said, you know, I've never called a press conference in my life, but that school has called many. I said, you have 5 minutes to get him a new locker, a new folders, or I'm going to have every media in the country at that school. For the first time in my life, I felt like I had a voice. We went through the court system, and just because these people were so ignorant and did not want to learn about this disease, the true facts about AIDS, I thought, I'm not going to stop. I'm going to support Ryan no matter what he wants to do in life. You know, I'm going to support him. Well, we ended up moving. I knew it was never going to get better. We lived AIDS every day of our life, from the factory where I worked, from notes being put up in my time card, from our tires being slashed, a bullet shot through our window. I mean, I just knew we were going to live AIDS in that community. We ended up moving to Cicero, Indiana, and it was unbelievable. Just because the president of the student body, Jill Stewart, lived 3 doors down. She went to school when she heard we were moving into the neighborhood. She said, let's make Ryan White welcome. The student council formed all kind of education, brought in the experts, health department. And the first day we moved in, 5 kids stopped by to introduce themselves to Ryan so he would know somebody the first day of school. I had 3 mothers that stopped by and said, we're there for you. Anytime you need us, we're there for you. Ryan went to proms, and he went to dances, and he's still living. He's still living after 3 years, and he ended up living 5.5 years. But he went to proms and dances and basketball games and all that. He even had a job at Maui Skateboard Shop, and I can remember him even coming home and saying, Mom, I've got a job. And I'm like, who's going to hire somebody knowing they have AIDS? I mean, you know, I'm even skeptic mom. And I said, how much are you getting paid? He said, $3.50 an hour. And I said, that won't even buy your gas to Indianapolis and back. He said, Mom, you don't get it. I got a job just like everybody else does. So you'd be surprised if people take everything away from you, how little those things actually mean. We ended up, the last event Ryan went to was with Ronald and Nancy Reagan. That they were having an Oscar party in California, and we flew to California. Ryan said, you know, I've never heard Reagan mention the word AIDS. If he'll appear with me, I want to be there. So we ended up going there, and the next night we had to fly home for the red eye because Ryan became very sick. So he entered the hospital for the last time. Elton John was by his side. And I love this story because it shows how important our health is and how literally, every day makes a difference. But Michael Jackson was also a friend of Ryan's. Always under a lot of controversy, I know, but the sweetest man. But he called the hospital, and Elton was filtering the phone calls and everything, but Michael wanted to talk to Ryan. And I finally talked to Michael. I said, Michael, he won't be able to hear you. He's in a coma. He said, no, he'll be able to hear me. I know he will. He said, is there any way you can get a telephone ran to Ryan's room? And I'm thinking, well, if anybody can, Elton can. Elton was kind of getting everything done at the hospital. Anything anybody needed, Elton was taking care of everything. So Elton got a telephone line, ran to Ryan's room, and Michael calls the hospital. Michael calls the hospital, and he's talking to Elton John. And he put the phone up to Ryan's ear. He said, Michael, you can say what you want to. I looked over at Elton, and he had tears just running down his face. I went over and put my arm around him, and I said, what's the matter? He said, with all the money that's in this room, we can't bring this boy back to life. It was a real realization to Elton. Every interview he does, he contributes his life being saved because of Ryan. He said, I had everything I could ever want, but I didn't have my health. He entered rehab. And we've seen him in all different kind of situations, alcohol on the piano, backstage, no alcohol anyway. We had seen all these demons that he had in his own life. But he ended up getting clean. He got a miracle. I tell you, people say, how can you do what you do? It's really hard to lose a child. It's the worst pain any mother could ever go through. And everybody tells me it gets better, but it doesn't. You learn to live with it because you have to, not because you want to. My son will always be in my heart. And I tell you, what I miss most is that smile. He used to always put his hand on my chin and said, Mom, everything's going to be all right. I'm still waiting for everything to be all right. Thank you.
Thank you very much, Jeannie, for that really touching remembrance of Ryan. I'm sure a lot of us didn't know all of those details, and so thank you very, very much, and for your continued involvement and commitment to HIV research. So now we're going to move to our first panel, the first of two panels that we have today. During the talks from Dr. Collins and Mrs. White Ginder, the rest of our panelists arrived, so we're happy to see that you got here. We have the panelists on the first panel today include, I'm just going to mention their names as we go down the line. You have bios for them. Dr. Deborah Hickman, Mr. Guillermo Chacon, Dr. June Gibson, Mr. Cornelius Baker, and Ms. Marissa Miller. So we're really happy to have this first group of community activists and community advocates, and we're going to ask Dr. Hickman, Reverend Hickman, to start with her story.
Good morning, everyone. I am here to talk to you about Sisters Together and Reaching and what we have done over the last 28 years in our response to the HIV epidemic. And in so doing, I am really honored that I got to sit next to Miss Jeanne this morning, because if it were not for Ryan White, if it were not for Ryan, we would not have had Ryan White funding these last 28 years, which has allowed us to do quite a few things. So I'm going to talk to you about who we are, and then I'm going to talk to you about what we've been doing and what we would like to do. So STAR's mission is to advocate and provide optimal health and wellness to underserved and at-risk minority communities in a holistic, faith-centered environment. Our vision is inspiring a revolution that nurtures the health and social needs of the current and future generations. Our history is brief, And in terms of the fact that we began Sisters Together and Reaching in 1991, when we had women that were living with HIV and or AIDS, and they were not being treated. They had no services such as what was being provided in Baltimore City at the time of HERO. HERO provided services primarily to the gay community. That's how it was known at that time. And there were no women that were being serviced in our community. So two doctors, myself, we got together and we met 5:30 a.m. in the morning, every morning, to talk about how we would move the church into position to be able to service the women that were living with HIV, but more so we had more deaths than we had those that were actually thriving at that point in time. And so we met and we met and we met. We sent a proposal into HRSA that was approved but not funded. The State Health Department of Maryland picked it up, and they gave us our first $30,000, of which we hired a peer person. That peer person in the form of Gwen Green, God rest her soul this day. She became our person that started our HIV support group for women. And Gwen lived a fruitful life because that little bit of money meant a lot to her while we continued to work 2 and 3 jobs just to keep the agency going. So we began our journey that way, and we wrote our first Jeanne White grant in 1991, and we were approved in 1992 to be able to provide emergency assistance as well as to be able to provide case management and the support group, of which, when Gwen passed on, the support group dwindled down to 1 because the women that were in that support group said that they could not come back to support group. And we kept going with that one person that did. And I'm not going to ask you to forgive my tears, because if you know how valuable life is, to hear women feel as though it might be them and they were afraid to come in the room because they had lost their leader, who valiantly every week was there for them, who they shared meals with and the like. So we went forward, and over time, the group built itself back together, and we ended up every week with 75 women in the room. And so as we went forward in the services we provided, today is a hard day. The services we provided, we asked the women, how could we make it better? And they said, if you would start offering services to our husbands, to our boyfriends, and the like. So we did. And we began to offer services of making certain that we had financial assistance available to them, making sure we had prevention activities available to their family members so that they would have better understanding, making certain that we had linkage to care services, and that we did capacity building with the services that the Centers for Disease Control began to offer us funding, and we were directly funded, and we put a mobile unit on the street. We put that mobile unit on the street so that we could get persons tested that would not go to the regular clinics, that would not go to the hospitals, that oftentimes found out that they were living with HIV or had full-blown AIDS because they visited the emergency department as if it was their primary care provider. So we believe that it is important to empower all of our community members, and that it is imperative that extraordinary efforts be made to identify those persons that are HIV positive, to ensure their entry and re-entry into the appropriate medical and support services. And also, we believe that stigma should not be tolerated by anyone. We all stigmatized ourselves, but having HIV should never have been a stigmatizing event, because everybody is at risk for HIV, not intentionally, but just because sometimes the human wants to feel another human in their arms, and they don't take the opportunity to go forth and make sure that that person that they actually are being intimate with has been tested, because they don't, and we don't still know how to adequately trust and talk to each other about HIV and or AIDS. The community we serve is the Baltimore City eligible metropolitan area, which consists of Baltimore City and 7 other counties that you see here on the map. Our current funders are Baltimore City Health Department, the Maryland Department of Health and Human Services, Johns Hopkins Healthcare Systems, and other local philanthropic entities and public dollars that we receive. Here's the mobile unit that is our third rendition of the mobile unit that we started putting out on the street in 1998 with funding provided through the Centers for Disease Control. This mobile unit houses 3 offices that we can test in. It also has a waiting area, and it has a front area where when persons come onto the mobile unit, the driver is the person that makes certain that they complete all of the information and they do a self-assessment of their risk. And then at the end, when they go in to see the counselor and they get tested, they are also talked to about what they stated was their risk, as well as what are the resources that they needed in order, if they were negative, if they tested negative, that we would be able to get them the other services to keep them negative. But if they were positive, that we would be able to immediately get them into care. These are some of the staff that have been working the mobile unit over time, as well as doing prevention work at the same time while we're in community, and doing pop-up shops with Johns Hopkins nurses today is what we do. We take blood pressures, we do mental health assessments, as well as we do mindfulness in community, because what we find is that there are more people that are willing to get tested when we offer them other options and not just make it a one-stop shop just about HIV, but we also do hepatitis C testing, syphilis testing, as well as that we listen to people in community and their woes of what they do from day to day that puts them at risk. And we believe that if we don't have this mobile unit in community roving not just through our city streets, but through the streets of the counties and other counties around us, that we would have more proliferation of HIV than what you would believe. People do want to talk more than just about HIV. They want to talk about sex. And that is something that here in America we do not want to talk about. We want to make it a missionary adventure that God is going to do something to us unless we do it this particular way, which is a shame because we need more commercials that show the real deal, the raw deal of what is happening in our communities and in our streets. We offer direct services that consist of spiritual counseling, health and wellness sessions, case management, support group, and all of the other services that you see here. The pictures are a demonstration of the communities that we serve, how we get them engaged, and how they stay involved, as well as the latter picture, the ending picture, is a picture of our men and women support group. We started hosting men when the women asked us to do something with their men. And these brothers come together and bring in other brothers. And on this particular summer day, we hosted a crab feast for them. And they really enjoyed themselves. And they brought in other people to also get tested. And here it is that in the church, can't say enough about the church. There are some churches out there that are still paralyzed because they cannot get out of their heads that they have brothers and sisters and they have sons and daughters that are HIV positive or who have full-blown AIDS, but yet on Sundays they stand behind a pulpit and they preach hatred instead of love. It's a sad day for me because I believe that our responsibility is to preach love and to be love and to make sure that everyone is incorporated. And if we're going to go forward in ending this epidemic, we must change the hearts and minds of those that are still stuck in a prison of hatred. Tumaini is our latest project that formed in 2012, where we began a journey with Johns Hopkins Hospital to be able to look at, along with Men and Family Center, another community-based organization that focused on the overutilization of the emergency departments, as well as the readmissions of persons that had just been discharged but were back in the hospital after 30 days. It gives us an opportunity to talk with them and their family members that about HIV and other other diseases and how the social influencers are impacting them. And I use the term social influencers because oftentimes we hear about the social determinants, which is very negative. But social influencers says that there is hope and that these are some things that we can do to work with and make certain that they get all of their needs met, and especially that they know their HIV status. And so we host community events such as the Why Women Cry Conference, such as community health festivals, National HIV/AIDS Testing Day, Christmas parties, World AIDS Day, testathons, and community walkthroughs with providers that want to know more about the community. This is one of our events where we actually, for the last going on 15 years, have hosted the Why Women Cry Conference. And at this conference usually gathers almost 3,000 women who bring in their young as well as their old, as well as men to this conference to learn more about HIV and from a holistic perspective, and how they can get into services, how they can talk to someone about their other ills that they have going on. Doctors come in and talk about diabetes. They come in and talk to them about cardiovascular issues, but they come in and talk about sex as well. So some of our concerns about ending the HIV epidemic and activities is that we've been hosting mindfulness sessions in some rare and different places, in police departments, in schools, as well as in senior centers, as well, I stated earlier, on the streets. And so these sessions have made others bring others to us to talk about some of the ills that they are feeling and forced to do because they're striving to stay alive, striving to survive on the streets without having to come into sexual contact that puts them at risk for HIV, hepatitis C, and the like. And so building community trust and reducing stigma, which I've already talked to you about as well, are some of the other activities. But community engagement is the one that I really hope to leave you with today, because I think that it is past time that we actually do community engagement. Community engagement means that it's not just you and I that are in this auditorium today, but it is also the church, it is also the businesses, it's also the schools, it's also getting with BG&E, it's also making certain that there is someone from the school system there that can assist in the process of sitting down and really thinking through how do we make sure every household has been tested for HIV? How do we make certain that people are able to freely talk about sex? How do we make sure that there are other avenues and venues for people to make certain that they are able to then make certain that they know the best way to communicate if they are HIV positive? So here you see some of the things that we've been doing. Storyboarding has become very effective in Baltimore City of getting people to come out and to talk about their status, but also talk about their fears of getting tested. And here you see us walking the streets with some of the providers that you cannot see in this picture that are up ahead of us, who want to be more engaged and involved and want to know how they can be better in their clinics at doing sex assessments and those types of things. And this young man that's walking alongside of me is asking me lots of questions about sex and how is it that people get still become sick, how are people getting infected, and why are we on the streets? We're on the streets because we need to inform our community. And so what we're seeking is a relationship with NIH that does translational research that demonstrates its effectiveness, but also is then able to be sustained in our communities. We don't need any more research being done that never hits the ground of our communities, but we need communities that have sustainable answers after that, and that we can all live and we can eradicate HIV. Thank you.
Thank you very much. We appreciate it. And our next speaker now is Guillermo Chacon from the Latino AIDS Commission in New York.
Thank you. First of all, I want to say thank you. Thank you for your words. It really, touched me and I'm sure the entire community that is watching. And we're grateful for everything you have done and you will keep doing. And I want to say thank you to the NIH for hosting this event, to the entire workforce. We appreciate, and the theme of this year, I think, is an invitation to remind us what Dr. Collins made and Dr. Goodnow making her opening remarks. We cannot leave anybody behind, and we need to put the center of all of our research and interventions, the communities that we try to engage. About the Commission, established in 1990, we are a 29-year-old organization. I was very lucky to be embraced and mentored by Dennis De Leon, who passed due to HIV complications in December of '09. And since then, I have been leading the Commission. We have been expanding our work to become a city, New York, state, regional and national, serving Puerto Rico and the U.S. Virgin Islands. And we are very, very dedicated to learn and partner from Black, white, Asian, Native communities, because it's when you do community integration, you come up with better strategies. Our mission is very simple. It's to contribute to end this epidemic, and we also believe since 2010 to develop a broad health perspective to put HIV in that context. We provide several services, from health education and awareness to prevention and access to care. And I underline that piece because care is fundamental when we talk about, and we're facing an older population living with HIV. We provide capacity building. We are right now located in the South, and we're very lucky to have partners like my brother's keeper in the South, along with NASTA, that work together to provide services to our heavily impacted region, but also important in terms of promoting collaboration and upgrading the skills or refreshing skills in providing services to the HIV workforce. We do health policy and community action, and of course, we also have a department that promote community research and evaluation as a core element to ensure that what we do will be validated and we could be potentially replicated in other places. We are very concerned from a Hispanic Latinx perspective about the lack of knowledge of our community. I'm sure you know that when we talk about Hispanics, behind that is a whole galaxy, folks from Mexico, Puerto Rico, Colombia, Venezuela, Dominican Republic, Central America, etc. And on top of that, you need to understand that foreign-born Hispanics are very different than U.S.-born Hispanics. And it's something that we know that NIH has been beginning to look into that, and I'm sure that will shape the creation of new customized and tailored interventions to respond to that reality. Also, the lack of understanding of how to navigate the healthcare system, especially for foreign-born Hispanics, is a deep concern from all of us at the Commission and our partners. We are aware about the linguistic and cultural, realities that we need to embrace, understand, and respond. We're very concerned about the growing reality of discrimination and racism. And also, from Hispanics to other communities and from other communities to Hispanics. It's a two-way road, and sometimes I get hit for that, but that's the reality. And the lack of Hispanic present in the healthcare workforce is also an issue of concern. Challenges that face new immigrants. So from 1990 census through now and on the eve of Census 2020, we know the trend and the shift on demographics in the United States that we truly believe that also call for all of us to go a little deeper to understand the realities that reality present to all of us. We also believe there has been a lack of research among understanding deeply, again, realities of Hispanics, Latinx in the United States, and especially an emphasis about the LGBTQ plus Hispanic community that we truly believe require also attention for us. And of course, I mentioned at the beginning that the growing older population living 50 years and older also represent and propel a whole different set of challenges to understand the comorbidities and implications that means living older with HIV. In terms of the current stage, I know I'm here full of researchers, and for the people looking at this amazing event to date, we're concerned about the increase over 2010, 2016, the impact of HIV overall in the U.S., and among other communities. Is a trend that we truly believe that has to be understood. CDC report in 2016, and I need to recognize the team of Dr. Vincent Gulano Ramos, based in New York, and the entire folks that contribute to some of these graphics and his research to go deeply in understanding the realities and implications of an invisible impact of HIV, and we truly believe that we will be going a little bit more up front to understand the challenges, especially to folks, younger gay men, bisexual, and trans folks that are heavily impacted. Latino men, again, who have sex with men is the segment that represent the largest new infections of HIV. And we truly believe that Latino young and we share the concern because our young folks engage in a different way, and it's something that we need to go deeper to understand the challenges of being younger and facing the realities of HIV and STIs and other implications that our community represent. I mentioned that recent new immigrants also represent a more demand of customizing, especially ongoing Spanish language messaging to try to connect with them. And again, when you see overall, even though Latinos represent 18% on the EVO census, this is still, the projections of the latest data. We will wait to see the census 2020. But among people of color, minorities, Hispanics represent a large segment of the population. But at the same time, we estimate that 27 new infections happen every day among Hispanic Latinos in the U.S. And this is, the 2017 data that also, sound the alarm for us to intensify our efforts and our initiatives. Again, we are concerned about the representing 18% of the U.S. population, but the 25 new diagnoses and the almost 22 AIDS diagnoses. That, by the way, that's as a segment of the population in the U.S., we are labeled as the late HIV testers. Many people show up and test, and they have a double diagnosis, not only HIV, but also AIDS. And that we know those that understand HIV deeply, the destruction in the immune system for somebody that receives an AIDS diagnosis is terrible because the immune system is hard to rebuild. And again, it's the fundamental piece for us to protect for so many other illnesses. Again, a lot of Hispanics are unaware about their status, and 1 out of 6, we estimate that, that's the reality. And that means that awareness and more customized and tailored interventions to promote testing as the most important way to connect and to walk people through to services and motivating them to stay in care is another big challenge that we have to address on this important World AIDS Day event here at the NIH headquarters. And again, we're concerned because 50% of Latinos have never been tested. That means we have a lot of work to do in terms of intensify these efforts. Again, when you look about the HIV rates, among Latina trans, 1 out of 4 are estimated living with HIV. And again, not only, doing something toward trans, but also empowering them to begin to lead their own efforts. Because when you empower somebody to begin to be in a leadership position, she will be the best, this segment of the population will be the best one to tell us how best to engage and to truly deliver a message of wellness, and especially when we talk about HIV, to prevent the spread of HIV. Again, we talk about foreign-born because this is a reality that we need to go deeper, but also in the time when we know that PrEP, and U equal U are the new vehicles to increase better efforts to prevent the spread of HIV, we truly believe that that's an important thing. On ending the epidemic at the federal level, we know that many Latinos in the 57 jurisdictions priority regions and counties are located Hispanic Latinos. And finally, I just will say that the partnership and innovative programs are crucial. We need to work local. We need a federal response, but more important, we need a statewide, and we need to include Puerto Rico as an important way to enhance our initiatives, and especially paying attention to the non-traditional partners. Media, ethnic media, social media, faith-based communities also will help us to make the difference, and we always will remind people that the South is an area of concern that we hope that we will do a better job. Thank you.
I just want to thank all of you from NIH who are here in this room and not down in Hatfield over at the gingerbread contest, because I almost stayed there when I came in off Theater Drive and didn't want to come in this room. It looks really good. And I want to, of course, thank Dr. Goodnow and Yvette and others for the very kind invitation to be here with you this morning. It's a pleasure to work with Dr. Goodnow during her time at PEPFAR's headquarters, and it's even more of a pleasure to be working with you all now as we're working to develop PEPFAR's global guidelines on stigma and discrimination. I'm not going to talk about an organization because I'm at Emory in detailed to work with Dr. Goodnow, and that would be really boring. But I want to, and I actually thought about today a lot, and I particularly thought about it. We had the good fortune of spending some time with Jeanne last night, and I had prepared a comment that I was going to say about her and Ryan and Andrea, and I reflected on it a lot last night and this morning as well, and I've been trying not to really cry a lot and thinking about it, but I just want to thank Jeanne so much for, just her grace, but to also just, say how much that she sacrificed. And when we think about the celebrities, Elton and Michael and others, and people who try to push their way in, we won't even talk about. But like many families and like many people, there was a lot of sacrifice. Leaving your home, leaving your church, leaving your marriage. So much that you gave up to do the right thing. And we're grateful. I just had to say that. I also want to thank all of you in the room, because this is a World AIDS Day observance, and we can talk about a lot about ourselves, but I want to reflect a little while, and maybe it's taking senior status, about you in this room. I moved to Washington in 1982 as a young artist, and did my internship at the Kennedy Center, and had intended to move promptly to New York, and had a position waiting at Lincoln Center. And I decided to stay for a moment, in part because HIV was scary in New York, and didn't want to go right away. In 1980, but I started working at City Paper here as an arts editor, and of course beginning to cover the arts in 1983 and 1984 also meant covering death, because the artists began to die first. And so I went to Lisner Auditorium in 1984 when Whitman Walker convened the Lisner meeting, as it's often referred to, and Dr. Fauci told us about this new disease, and there were hundreds of us there sitting on the floor and really trying to understand what it meant for our lives. And so the first acknowledgement is that, of course, that it was the voice of the NIH and Dr. Fauci's leadership that informed us, and it propelled us into action. And so I, with so much death, I found it difficult to create anymore. And so I became an advocate, and I began fundraising, and I did everything that needed to be done to respond to our lives. But that was made possible, and it continues to be made possible by the evidence that you produce. And so I really just want, and that's whether it's the most basic of scientific evidence to things that inform us in understanding transmission patterns or new drugs, et cetera. And so the work that you do here is so foundational to everything that we aspire to achieve in ending HIV. In the 80s, I was diagnosed in 1986, and I've been a study participant here since. Everything from GP 120, which we thought would be a therapeutic vaccine that would save our lives. And I should have known better when the study investigator, who was a gay man at Georgetown, died and of HIV, that this probably wasn't going to work out. And I remember talking with the study nurse, Rosemary Duffy, about it, and when the study was ending. And she says, no, it just didn't work out. But she says, there was this new test that was part of this trial called viral load. And we don't know what it means, but it looked really good. And that nurse in that moment offered hope and an ongoing opportunity of survival. And, and I've been in studies like those that Frank Maldarelli does upstairs that, where he's branching off the HIV trees and stuff like that. And I have no idea what he's doing. And he gets so excited, and he likes to show you his study results and stuff. And so, we need more trials, not less. We need more research, not less. And we need a research enterprise that continues to inspire us. And for those of us who have been fortunate to survive, to help keep us alive and going, and to aspire towards an absolute end to this. Our 2030 goal is great. We need to reduce the new diagnoses by 90% by 2030. That is not an end to HIV. For those of us who changed our lives and committed to seeing it to the end, an end means a vaccine and a cure. That's the end. And it means every single person having it. And as we know, when we look at measles and polio, having the vaccine or the cure is still not sufficient. And so we have much more work to do. And then the only other reflection of NIH and our work and partnership together that I like to offer is that I had the good fortune with Dr. Peggy Johnson's leadership of working in, one of our wonderful staff persons from FHI 360, Alessandro Gravina, who's now here, of working on the NIAID HIV Vaccine Research Education Initiative. And which was very important to helping communities understand and come to support vaccine research at a time that there's a deep skepticism. We still live in the shadow of Tuskegee, which was in our lifetimes. I think it's very important that, particularly for those of us who are over 50 or 55, that we recognize that we live within the lifetime of not only just terrible atrocities like Tuskegee, but we also live within the lifetime of segregation. We live in a lifetime before blacks could vote in this country. We live in a lifetime that has seen the worst of humanity here. And those memories will not fade quickly. So we have to do ongoing work to restore trust, to restore faith, to restore community. And so that the work that gets done here isn't empty work because people won't use it or won't trust it. And that's an ongoing task. And I think, we hear around the country, there needs to be more and greater investment in it. The NIVRI project has lapsed in its successors. And I think we need to look at how do we bridge the scientific enterprise to the community in a much more direct and structured way, that it can't be haphazard. June, do you have your slides? So good. I'm going to close with just a reflection then, about this commemoration. Yesterday, I was at the cathedral, and it was inspiring because World AIDS Day was also the first Sunday in Advent, and as a Christian, the coming of the prophet, the revolutionary prophet, is always a deeply inspiring moment to me. And because he does the work, and he taught us to do the work that Jeanne did in a critical moment, your faith lived and showed within you. And so tonight I'll be back at the cathedral as we commemorate the life of Matthew Shepard, who reminds us of the work that we still have to do. And so I'd like to just end by reflecting that this year's commemoration of World AIDS Day is also in a year that we commemorate 1619 and the arrival of the first slaves at Old Port Sumter in August of 2019 in the British colonies. But 1 month before that, the House of Burgess was created and sat on July 30th in Jamestown, Virginia. It was the first democratically elected legislature in the New World or any world. And it led, of course, ultimately to 1776, where that democratic legislature declared itself independent of Britain and its monarchy. The first person to die in Boston at that protest on the harbor was Crispus Attucks, a free black man who lived the inspiration of those first slaves to be free. And of course, the United States became the first country in the world to become independent of its former colonial power. We are great people who can do great things when we aspire to them. Ending HIV will be a great thing, but it will only come about if our aspirations around democracy, around inclusion, around representation overcomes our history of enslavement, of exclusion. If we do not include the black and the brown and the gay and those who suffer diseases like hemophilia as the voice and at the forefront of our work, we will fail. We have not done well by black gay men here at NIH. We have not done well in our networks. There have been too few studies and too little emphasis. HIV is a disease of geography, but it is also a disease of populations. and we have not included and respected all populations in our response. We can do better. And I hope that my aspiration is that looking at all we've done so far and reflecting on not only this World AIDS Day, but 1619, that we will aspire to be as great as the patriots who've come before us and who still live with us, like Jeannie.
Thank you very much, Cornelius, for sharing that with us. And now we are going to have Judy.
So I'm going to talk about what we do in Mississippi as a community-based organization. So the mission of My Brother's Keeper is to enhance the health and well-being of minorities through leadership in public and community health practices, collaborations, and partnerships. And we do this through three main centers. The first center I'm going to talk about is the Center for Community-Based Programs. This center was established to promote and facilitate healthy lifestyles and strengthen connections and mobilize the community. This is pretty much our grassroots effort center, and then within this center we have all of our prevention and our training projects. Some of our prevention projects include CDC's 1502 and 1704. We also have training projects, which is TPP, which is Teen Pregnancy Prevention Project, which is funded by the Office of Minority Health. We also have the I CAN project, which is funded by the Packard Project, and APAC, which is the project that Guillermo mentioned about us working throughout the South to increase clinical testing among community-based organizations and health departments. One of our programs that we work that falls on NIH is going to be the MBRE. Mississippi MBRE is, I'm so sorry, this cold has me. The MBREs promote the development, coordination, sharing of resources and expertise to enhance the researchers within a state. So in Mississippi, we don't have a lot of researchers, but we want to increase that. We are considered to be the community-based arm of the Mississippi MBRE. Our role is basically to take the biomedical research students and to infuse public health into what they do. And we do this through the Service Scholar Program. The Service Scholar Program consists of four main components. We have the training component, we have the professional workforce immersion, we have research, and we have debate. And within this program, we want to increase the awareness of the vast array of public health settings which biomedical research is practiced. So they come within My Brother's Keeper and they work throughout all of our centers. They learn how biomedical research actually merges with public health. Within this program, first we have the 2-week piece. They come in and we pretty much teach them about public health, what public health looks like. And we also tell them, what does public health intersect with biomedical research? And then they go into the professional workforce immersion. So they work with different mentors throughout My Brother's Keeper and Open Arms Healthcare Center. And they work with us for 10 weeks, learning what we do, how we do it, where we do it. And then they also have to do research. And within that research, they can either do primary or secondary research. Primary research being they can create a study, or secondary research meaning they can take something that we already have developed. But we also do debate. We want our students to understand public health and how to debate public health, not to argue public health, but use facts to make decisions around public health. As we know in public health, decisions are made, people come up with rules based on how they feel, not based on facts. And so we want them to be better prepared when they enter the workforce to understand how this actually works. Some topics that we have that are really interesting. One is going to be, should federal prisons be required to provide sex reassignment surgery for transgender patients? And so the kids had to debate the pros and cons of this, utilizing facts. Thank you so much. And you have to know that the pros actually won. The students pulled the facts based on what the federal prison has to do and how it has to treat its patients. Our next center is going to be the Center for Research, Evaluation, and Environmental Policy Change, which we call CREEP. Now, within CREEP, we don't do a lot of projects per se, but this is where we have all of our data warehousing. So all the data that we collect from all our projects housed within this center. This is also where all our quality assurance people are and our evaluators. And we do clinical quality assurance. So basically, we have a primary health care clinic. Within this clinic, we have individuals who check the charts every day. They're going through to make sure that everything has been uploaded into the system. They also make sure that the physicians have charted. If you all have any knowledge or background in the clinical arena, you know the first and worst thing that can happen is when the clinician doesn't chart. You can't get paid, and your patients don't have the information that they need. But we also have programmatic quality assurance. Within programmatic quality assurance, we do a 3-month quality assurance check on all of our programs to make sure that they're all up to date. Our next center is going to be Open Arms Healthcare Center. Let me get some water. Okay. Open Arms Healthcare Center was established in 2013, and it was established to provide innovative, holistic healthcare services, including preventive, clinical, and mental health to underserved, uninsured, and underrepresented populations in Mississippi, with an emphasis on the LGBT community. Open Arms represents the first and only LGBT clinic in the state of Mississippi. Within Open Arms, we do women's health, family planning, men's health, PrEP, transgender health. We also have a program called Becoming a Healthier You. This is our flagship program. This is where everything pretty much started for us. Within the Becoming a Healthier You, we provide glucose, cholesterol, HIV, syphilis, gonorrhea, chlamydia, BMI, blood pressure, Hep C, and Hep B screenings for free. And it's done any day of the week. It's an opt-out process. So basically, you have to tell us what you don't want. And so this was our way of pretty much eliminating some of the stigma around HIV, and also, as Dr. Hickman mentioned, giving people something else outside of what you need to have. So essentially, we need HIV tests. That's not something the community needs. This is something that we need. We have to have these numbers. But it's not fair just to give them this one element, because in Mississippi, there are a lot of things that are happening. Healthcare and health is all over the spectrum. And so if I don't understand your diabetes, how do I understand your HIV? If I don't understand syphilis, how do I understand HIV? And so we merge all this package together to be able to provide services to the community. We also provide mental health services, transportation. We have an on-site food pantry. We do legal services. And October 4th, we open our first pharmacy. And all this is located within the clinic. So it's a one-stop shop for our patients. Some of the other highlights of what we do at Open Arms as it relates to NIH, since the conception of Open Arms, we've always been about discovery. We wanted to make sure that we understood not just the preventive end of things, but if we're going to provide clinical care, how do we understand how to make it better? And we felt like we had a very unique opportunity where we would have the community, we would have the population within our own clinical healthcare services. And so we have, as of today, we have 4 HIV prevention, 6 clinical trials, and 8 biomedical behavior studies that we've done within Open Arms. And we do these within partnerships with the University of Mississippi Medical Center, New York University, and Columbia University. And we have been a part of over 30 peer-reviewed publications. So one project that we have is called the MARI Project, and MARI is funded by CDC, and basically we're looking at how social networks work, how people actually move through their neighborhoods and through their communities. We also had a GPS study, which is funded by NIH. And with this study, we actually had the guys to wear GPS devices to see where do they go. How do we understand your networks? What happens within your networks? When do you decide to have sex? Where are you in that point in time? So we can better understand how we need to market and how we need to service those communities. We also have the HIV Cure Project. This is funded by Gilead. And when we talk about the HIV cure, there's always this notion that everyone's going to run to it. That the moment it's there, people are going to say, yes, I have to have that. But we're not so sure. HIV is a thing within itself. It's a community. It's a social support service. It's so many things that go along with HIV. Housing, food, how I live, where I live, my social network. And so we wanted to understand, will people want the cure? Is that something that they're going to sign up for? Also, what comes along with the cure? What changes within your life if you're cured? We have a hepatitis C cure, but everyone doesn't get it. So it's the same notions to work with HIV that everyone may not want the cure. And we also had the SHIP study. The SHIP study was funded by CDC Foundation, and this looks at the cost and the sustainability of PrEP. And mind you, we provide 75% of all the PrEP throughout the state of Mississippi. And so we need to understand, does it balance out? If you want someone to stay on PrEP, what needs to happen to get them to stay on PrEP? Is cost going to be a factor with it? What are going to be the outcomes of someone being on PrEP? And you would think, hey, they're on PrEP, they stay on PrEP. But just like in any other element of medication, I may be on something for this moment in time. It may not be something I want to stay on for the rest of my life. And so we did research to understand what would actually keep someone on PrEP and what happens when a person says, I don't want it anymore. And then we have clinical trials. We have clinical trials at Open Arms, and the first one's going to be funded by NIH, and this one's basically looking at gonorrhea. And we also have another trial that looks at the specimens that are collected at a sexual health clinic. And then we have other that looks at point-of-care testing. Other clinical trials we have also look at trichomoniasis. We have clinical specimen protocols, and then we also have a study that looks at the diagnostics for trichomoniasis and chlamydia. Some of our NIH studies are going to be multi-gaming interventions for persons on PrEP. And so basically this is a game that was created to understand someone being on PrEP and what behaviors do they practice while they're on PrEP. Then we have a retention in PrEP among African Americans in Mississippi. That's also funded by NIH. We have the mobile intervention to improve the uptake of PrEP among Southern Black MSM. And then we have the characterization of HIV PrEP within African American and Latino men with Mississippi. We also have telemedicine for PrEP throughout Mississippi, and telemedicine is something that's huge for us. We actually provide telemedicine. We're in a rural area, and you're not always able to get to everyone the way that you want to. And so telemedicine is actually offered at 2 of our centers, and we do teleprep and we do telenutrition. We have another mobile gaming app that's funded by NIH. We have another PrEP study that's funded by NIH. And we have a STD transmission study that's not funded by NIH. And one of our newest things is going to be our relationship with Shield Bio. And Shield is a diagnostic center. And so we're looking at resistance. You know, we provide a lot of antibiotics, and resistance can become a part of antibiotics. And so we actually have a monitoring team that's come together to look at how we're prescribing to ensure that we're not over-prescribing our antibiotics to our patients. Thank you. I'm so sorry. Man, it's been a long week.
Thank you, Jeanne. And finally, we have our last speaker for this morning, Melissa. And do you have slides, or are you going to sit there?
I'm going to sit.
All right.
And I am going to be cognizant of our schedule. And so it is certainly a pleasure anytime that I am invited into a space to share my experience or to share the experience of my siblings. And so I invite people to be careful when we introduce comments and sections into narrative and we say ladies and gentlemen because we leave a group of individuals out. We leave our non-binary and gender non-conforming siblings out. And so certainly thank you, Maureen, for the invite. And so we had a wonderful time last night spending time with Jeannie and some of the other extinguished panelists. And so my work is singular today. And so I was privileged to be the Senior Strategic Director for the National Transvisibility March that took place September 28th in Washington, D.C., where we mobilized a little bit over 5,200 people. And the work that we'd done leading up to the march was the most pivotal work. We knew that we were not going to be included in the census. We knew that we were not going to be included in the narrative for the federal plan to end the epidemic, and we knew that we were not included in a lot of the bills that were being introduced into Congress. And so a lot of the work that we did in the first year was just about visibility, and we wanted to show individuals across country that we were visible. A lot of the work that we done was in partnership with HRC. We were in partnership with Rock the Vote, in partnership with Gilead and some of the other pharmaceutical companies. We were able to scholarship a little bit over 1,500 individuals that had never had the experience of being around other trans, non-binary, and gender non-conforming individuals, or never having the experience of what a a march looks like. And so we were very fortunate through funding to be able to house individuals for those 2 days. We were also able to, throughout our programming, honor 25 individuals that have been doing the work around trans, non-binary, and gender non-conforming work for the last 25 years. And so we were able to celebrate that work. And we also, which was really important for us, we were able to honor 6 emerging leaders. And those were people that have been doing the work under mentorship of our elders. And I was in an interesting conversation yesterday with my colleague, and I was sharing with my colleague about space at the table. And I drove home yesterday from Maureen's house, and I was thinking about what space looked like and what inclusion looked like and what diversity looked like. And I realized that it's not a conversation, it's an action. Diversity becomes something that is natural, not something that we had to add at the end of the program or something that we have to look for. I think that when we talk about ending the epidemic, we've certainly realized that adherence to HIV medication, and I qualify, I tested positive October 18th, 1990. So I've been living with HIV for quite some time, and I've learned how to navigate through HIV. And I guess before I go to talk about what our recommendations are from the community, I'd like to talk about how Ryan White Services saved my life early on. You know, they introduced, when they started talking about Ryan White in the beginning, it was for people that lived in poverty, people that did not have substantial income, and I was one of those individuals that was just exiting. And I don't share this story much, because this story is a part of my past, and I've moved in a different direction, so my narrative changes when I move in a different direction. But I tested positive in the Department of Corrections in 1990, way before pre- and post-test counseling was available. It was when you got your diagnosis and they sent you to a cell and you were to deal with what you were to deal with. It was when the pamphlet said that you could not get HIV from touching, and you could not get HIV from using the same toilets, and you could not get HIV from existing in the same spaces, yet they kept us isolated. And so I look back over my life and realize, when did I become an advocate, and when did I begin activism? And it was in 1990 when I wrote that grievance to the Department of Corrections, telling them that these were cruel and unusual circumstances that they were housing people under, and it changed the way that people enter into the Department of Corrections. And that is a community that we can't forget. And so I think when we look at our recommendations from the trans community, one of the things that we realize, and next year I'll be 50, so I enter into another group of individuals, and that is a celebration, because the Medical Association has put our lifespan between the ages of 30 and 35. So my recommendation and some of the things that I like to see, and I also want to commemorate those lives that were lost. I think that we got so pushed in celebrating and so pushed in talking about our agencies, but this day was never about an agency. This day was about the lives of those who have passed from the pandemic. So we never took a moment of silence, and I'm a spiritual person, and I want to just take one moment of silence to celebrate our ancestors and to bring them into the room and to bring their experiences into the room and to bring their healing into room. And so if we can just have a moment of silence really quickly. Thank you. And so in ending, our recommendation is, so we know that we're not in a lot of research projects, and I know that one of the projects that we are featured in is HIV and aging. And so the contradiction for me is, how can we be HIV and aging, and then you have our lifespans at 30 and 35? There's a contradiction there. And so we also like to look at, we've identified that adherence and prevention are 2 of the components that are going to end the epidemic, and we also have added equity. And let me share with you that equity doesn't mean that everybody gets some. Equity means the people that need it the most get it when they need it the most. And so if we're really looking at ending the epidemic, and we're really looking at engaging workforce development as a system to end the epidemic, then we really got to look at equity and make sure that those who need it the most get it the most. We've also got to make sure that those who get it keep it. It's one thing to give a gift, but it's another thing to be able to keep the gift. And how do we teach people in a culturally responsive way how to keep what they have? And I think that the third recommendation that I think that we often miss is safety. We can't end the epidemic until we address safety. 23 Black trans women have been slaughtered in the streets. And I think when you talk about ending the epidemic, I think most trans people, we would rather die from HIV than be slaughtered in the streets. When you talk about winning, when a population's winning for the trans population, Araya Lester, one of my colleagues, said it best, is dying from natural causes, not dying in the streets. And so I think that we really have to look at, from a perspective of research, is safety connected to adherence? Is safety connected to medical adherence? Is safety one of those things that we're willing to look at? Because I think that we often operate, and I certainly have over the years operated in a different sense of privilege. You know, I drive. I park in my garage. I lock my garage. You know, I live in a neighborhood, thank God that he's afforded me the opportunity to live better. I think that we have to look at those systems when we're talking about housing and we're talking about substance usage, and we are still placing people in neighborhoods that don't allow them to thrive. And I don't think that housing is successful in those particular aspects. So I am certainly grateful to be here. And the last thing is I just left NMAC on September 30th to get ready for 2020. And we need you for 2020. The National Trans Visibility March will be October 2nd and 3rd. It will also, again, be in the streets of Washington, D.C. We will gather on October the 2nd to honor 25 more trans, non-binary, and gender non-conforming people that have been doing the work across the country. And on the following day, we will get up and we will walk. We will not be counted in the 2020 census, so they would once again have to count us in the streets. And so our website is transmarchondc.org. transmarchondc.org. It is not enough to just have us as girlfriends, hairdressers, peer educators, linkage to care specialists, outreach workers. Our lives mean more. And so we encourage people to support the National Trans Visibility March. Go to our website. It was a $1.5 million project the first year. We're sure that it will be a little bit more expensive this year, but we are excited about voting. We're part of our platform for 2020 is our partnership is with HRC, ACLU, and with Rock the Vote to ensure that we can be on the ground starting in January to ensure that people get to the polls, people have opportunity, people know their rights as it relates to voting. And so we're not positively sure about a candidate. We just want someone that is going to treat us fairly. You do realize that our lives don't exist if 45 gets back in office. Again, all of the rights, the few rights that we have left will all be gone if we don't make a difference. And so I'm certainly glad to be here, certainly glad to be living and thriving with HIV, not dying from HIV, but living and thriving for HIV. And so it's been a pleasure to be here. Thank you.
We have our second panel, and I'm just going to let you know and introduce you to the moderator of the panel, Dr. Timothy Holtz. Tim is what does he do? He is the Deputy Director in the Office of AIDS Research, and he's been there about 4 or 5 months now. We're delighted to have him. He's a captain in the U.S. Public Health Service, and in the past he has served as the Global Health and TV Prevention and Control Programs overseas, and more recently he was stationed in India where he implemented the CDC's PEPFAR strategic objectives. So Tim is going to be moderating the panel, and he will be introducing the panelists. Thank you.
Thank you, Maureen, and good morning, everyone. Still is morning. I wanted to welcome everyone to session 2. My name is Timothy Holtz, NIH Medical Officer and the Deputy in OAR. And I wanted to thank all those who are on the video cast and those as well as in the room for remaining with us for this second part of our program. I'd also like to give a special thanks to our NIH AIDS Executive Committee and members of the Office of AIDS Research Advisory Council for your attendance. I'd really like to first say a sincere thank you to those on the first panel and the moving and truly inspiring words and personal testimonies of Jeannie and Reverend Hickman and Cornelius, Marissa, and others. Really incredibly touching and moving for me, having worked in this on the epidemic for 10 or more years. And I think our second panel here, who's joined us, really has a tall order ahead of them. But in reading all the bios, I'm really fully confident this will be just as educational and inspiring a session. I wanted to add just a brief voice of support and commitment to community leadership and collaboration with NIH in clinical trials and as well as in basic research. And I'm not going to say much because we might be pressed for time. I wanted to make sure we have room at the end for questions and comments from the audience. But I just wanted to add that I was given a quick study of the importance of community involvement in leadership 10 years ago when I became a site investigator of a CDC-funded and run clinical research site that was carrying out NIH-funded trials in Bangkok with MSM and transgender populations. And we had not one community advisory board, but two, actually. And then we added another transgender community advisory board just because it was so critical for us for every study that we were doing on pre-exposure prophylaxis. So I think with that, I will introduce each speaker individually. For those who are on the videocast may not have access to the bios. Dr. Pernessa Seal is the founder and CEO of Balm & Gilead, a not-for-profit organization celebrating 3 decades of providing technical training and services that strengthen the capacity of faith institutions in the United States and Africa to promote health education, disease management, and services that contribute to the elimination of human suffering. Dr. Seal. And you can either remain there or come up to the podium. It's up to you. And there is a timer up here, just as a reminder when you see the yellow light. Thank you.
Good morning. I do not have any slides. Isn't that great? Which means I will hopefully stay on point. 31 years ago, around this time, I was at Harlem Hospital. I had been a hardcore scientist. I was working in toxoplasmosis in research at 1600 Clifton Road in Atlanta. I had done malaria research at Rockefeller University. I had done cancer research at Memorial Sloan Kettering. And then I decided I did not want to do any of that anymore. But the one thing that was happening in New York City was the AIDS epidemic, and it had something to do with the immune system. So I became one of the first AIDS educators in New York City and worked in drug rehab centers. But then I found myself at Harlem Hospital working under Dr. Wafa El-Sada in infectious diseases. And my role was to go up and see patients every single day. And I was just amazed. I was devastated because I come from a community in Lincolnville, South Carolina, where when you were sick, the church folks came. When you died, the church folks came. And everybody in Lincolnville, South Carolina, where I grew up, everybody who left went to Harlem. And here I was in Harlem, the mecca of black culture, and that was not my experience. And I could not understand why. I was two days into this new job. And you know, I got an idea. And that idea was to mobilize the faith community of Harlem to address HIV and AIDS. It was a dumb idea because I was not clergy. I did not know anybody in Harlem, not one clergy. Matter of fact, I had no hair at that time. I have more hair now than I've ever had in 30 years. But yet there was something burning in me that the faith community had to be on the front line of HIV and AIDS. And the idea that came was the Harlem Week of Prayer for the healing of AIDS. Certainly, I was not the first person to knock on the church doors of Harlem to get them involved with HIV and AIDS. But I did not go to them with a condom and a banana. I went to them with something they could relate to, a week of prayer for the healing of AIDS. One of the most important things we've learned over these 30 years is that cultural competence matters. Cultural competence matters. It was an AIDS education, AIDS awareness program, initiative. And it was not just Christian, it was everybody. Everybody who believed in the one God came. And it was just amazing. I wish I had time to tell you about that Harlem Week of Prayer for the Healing of AIDS that gave birth to the National Week of Prayer for the Healing of AIDS that we now do in March, the first Sunday in March. In 2020, it will be our 31st year. And we have so many hundreds of churches, thousands of churches all over the country still doing the week of prayer for the healing of AIDS. That little idea also gave birth to the Balm in Gilead. And the Balm in Gilead is where faith and public health connect. Why? Because I'm the founder. And I am faith and public health. Cultural competence. You hear so much about faith and the devastation of what we have done to our lives. But there is another story as well. That so many churches, whereas we talk about always the stigma and the horror that church folk and faith folk have done. And yes, they have. But we don't lift up those churches who have been in the trenches with us. The mosques all over the world have been in the trenches with us. Stigma. I think we would all agree that when we talk about faith communities, the first thing that comes to mind is stigma. That is the entity. We got to get the faith community to really dismantle stigma. That is true. There's another stigma that goes on, and that's from us. Those of us in scientific quarters, that we stigmatize the faith community because we have a myth that the faith community does not support HIV or does not support gay lifestyles or does not support transgender. This is not true. Because the faith community consists of everybody. It is a subset of the community we're trying to reach. Everybody in the church is who we're trying to reach. There are people who are living with HIV in the church. There are gay people, there are straight people, there are transgender people, there are sexual abuser people, there are sexual victims. Everybody is in the church. The one thing about working with faith communities is that, successfully working with faith communities, is that you really must be able to not put your Jesus on somebody else's. That's the key. Because oftentimes we either think of the faith community as, shouldn't they be doing something what I want them to do? Or why are they doing that? That's another 10 minutes, so I'll move on from there. The Harlem Week of Prayer that gave birth to, in 2000, our church lights the way on HIV testing. It became the launching point for getting African Americans tested in the United States. CDC began to take notice because they saw that when the church started doing HIV testing, 100% of the people came back for their results. If you remember, when testing first started, people would get tested, but they didn't come back. Well, when the church started, people came back because, in addition, what the church offered were people who had a compassionate response. Let's pray for you. I'm going to walk with you. And I want to give a shout out to my colleague, Deborah Hickman, and all of my colleagues here today who have been in this fight, because this is not easy work. This is not easy work at all. So CDC took notice of that churches were really in the trenches of HIV testing. In some cities, like Wilmington, Delaware, and Cleveland, Ohio, the health department decided to give the funding to the churches because the churches were doing more testing than the actual health departments, because people trusted their people who were going to the church. Something like Reverend Hickman's Sisters Together in Reaching. We trust the church. We know what church to trust. Somebody say amen. In 2000, the Balm in Gilead, we took our learnings from the African American church and we launched our Africa HIV/AIDS Faith Initiative in 6 African countries. We were funded by PEPFAR for 15 years, mobilizing the Christian and the Muslim community in 6 African countries. That's another 30-minute conversation that I cannot tell you about. Well, what did we learn? One of the initiatives we took from this country to Africa was that Lights the Way program. In Africa, it was Our Faith Lights the Way, because it was both Christian and Muslims. I remember going into Nigeria when Christians and Muslims, they were killing each other. But guess what? The HIV virus brought them together. The HIV virus was that thing that connected the Catholics and the Protestants and the Muslims. When we did an HIV testing with Catholics and Protestants and Muslims in Africa, you would have 6,000 people getting tested in one weekend, in one country, in Tanzania, where we still have an office. Numbers, the shared numbers that we have working through the faith community, and we know that it is the most influential institution in the world. But what we don't understand is that how do we work with this entity? We learned a lot in Africa, and we brought some of those learnings back to the African American community, because cultural competence with black folks reach across the pond. We understand that our belief in God and our belief in prayer and our belief in faith sometimes will keep us from taking our medication. Sometimes will take us from getting tested. So we have to focus on our leadership. And that's hard because it's long. It takes a long time, 31 years. I know about the longevity of this. It's just like getting a vaccine. It takes a long time. I remember 31 years ago, and please give me a nod because I don't know when I started. I remember 31 years ago when we had some leadership, faith leaders in place, and they wouldn't hear about HIV. And I would just say to people, we're going to just have to wait until they die. And guess what? As life would have it, they died. That's not a good or bad thing. That's just the way life goes. And so now we have a new generation of leaders who are more welcoming, who are more diversified. We also now do clinical trials through our churches. We have a clinical research response. One of the major things I want to leave you with today with faith community is to understand that the faith community is not something to fear. It is your mouthpiece. It is how we get our information out. It is how we change social norms. When I'm talking to my pastors, I have to remind them that some of the folks, the mothers and the fathers who are shouting on Sunday morning and crying on Sunday morning, they're not shouting and crying because you're doing a good sermon. They're shouting and crying because they did not go to the bedside of their son when their son died of HIV 20, 35 years ago because of what you said, Pastor. We're able to have some real conversations if you don't get fearful in terms of the response. And churches are doing great. Some churches, many churches, have changed. On Sunday morning, it's a choir room. But on Monday through Friday, it's a HIV testing place. Some churches bring in the clinic to the church during the week. They're doing research. They're doing food. They're doing all the things that are necessary. Lastly, the Balm in Gilead, we are a public health education organization targeting the faith community here in the United States primarily and in Africa. Right now, today, the Africa AIDS Initiative is happening, conference is happening in Rwanda. And we are there hosting a summit on the faith community's response in Africa. Last week, we were at Charlotte, North Carolina at our Healthy Churches 2020 conference, talking to faith communities around the strategies, the role of faith communities, the Black church response to ending the epidemic. Everyone comes to this conversation with some type of belief. And we believe it is your belief in how you see your relationship to God that matters most in your life. So the Balm in Gilead, it's where public health and faith connect to change the paradigm on HIV and other health disparities. Thank you so much for your time.
Thank you, Dr. Seal. I'd next like to invite my colleague and friend, Mitchell Warren, who is the Executive Director of the AIDS Vaccine Advisory Coalition and has served in that role since 2004. Mr. Warren is a member of the Scientific Advisory Board of PEPFAR and president of the Global HIV Vaccine Enterprise. And in 2013, he helped establish the biennial HIV Research for Prevention Conference and is one of the co-chairs for R4P 2020.
Great. Thank you so much, Jim. And thank you, Maureen and the OAR, for inviting me and for organizing this. I have two great confessions to start. One, it started actually, Jeanne, when you started this morning. I thought, God, I'm glad I'm not following her. And unfortunately, that's been the case for the last 7 people. I'm going to make it easier for the last 3. Consider this a palate cleanser. But what a remarkable thing. My second big confession is that I'm not a huge fan of World AIDS Day. I've been working in this field, as many of you in this room have, for far too long. I don't want a day that we have to remember. We need one, but I wish we had a world in which we didn't need one. But I also am struck, because in my 30-plus years working around this epidemic, I'm struck by the number of people who aren't in this room, who do think about HIV once in a while, and maybe on December 1st. And the reality is that if we are to end this epidemic, and I fundamentally believe we can and we will, we can't do it one day a year. And we really can't even do it one day at a time. We've got to pick up the pace, because we are at a moment in this AIDS response now, 38 years later, where we do have, as you heard from the very beginning this morning, we do have an amazing opportunity. And that opportunity, if squandered, doesn't come again, or certainly doesn't come again as easily. So I stand here today both invigorated and excited by everything I've heard, invigorated and excited by what's happening in the field right now, but nervous that we are not yet taking full advantage of all that we can do. And one of the things that strikes me in listening to everybody today is that very often in not just in HIV, but in a number of these types of issues, we tend to create silos between communities. You know, we talk about scientists, we talk about advocates, and if I look back on 38 years of history of this epidemic, there's actually some remarkable things that have happened in science and in community activism. But the most remarkable things, and the reason that we even stand here in 2019 even talking about the end of an epidemic, is because science and advocacy came together. Some of the greatest science has happened because of community. And some of the greatest community actions have happened because of the links with science. And I think about some of the great citizen scientists that got us drugs faster, Not always an easy time here on the NIH campus when people were, it wasn't a kinder, gentler period, actually. It was a time of great protest. But if not for those activists, we wouldn't have more antiretroviral drugs for HIV than for any disease imaginable. And at the same time, if it weren't for great activist scientists like Wafa El-Sadr, like Tony Fauci, we wouldn't have the advances we have. So I want to just, perhaps, I'll start where I hope I end, which is that we have to think about this not as science or activism or science or community or scientists or advocates. It's about how do we wear those hats comfortably together, each one of us, irrespective of our training or of the organizations where we sit. I'm going to take a bit of a quick tour through prevention at a really amazing time. I mean, I stand here and actually I'm amazed that we even talk about ending the epidemic. I've worked in this long enough where that was a pipe dream for so long, and things changed about a decade ago. Beginning almost exactly 10 years ago last week, when a study was published that showed an HIV vaccine was possible. It ushered in a series of findings in 2010 and 2011 that showed us that antiretroviral prevention, or PrEP, was possible, and culminated in May 2011 when the HPTN 052 trial, looking at treatment as prevention, showed us scientifically what we thought, which was that actually what we now know to be true: undetectable is untransmittable. And if you think about it, before 2009, when we talked about ending this epidemic, it was really more dream than possibility. And now we stand where it's possible. But this is just a quick snapshot that in 2014, in the midst of all of that excitement scientifically and in communities, there was a huge push to declare targets, the 90-90-90 targets as we know them, that we could end this epidemic. And I am the first one who wants to end this epidemic. But I also don't want to declare success too soon, because we are not near success. We've made huge progress, but never, ever confuse progress with success. Because those targets that were established for 2020, which is just really a month from now, and giving target makers the benefit of the doubt, giving them till the end of 2020, we're 13 months from the end of targets that said we should actually be towards epidemic control. And while there is huge progress, we are not where we need to be. And to give you an example of that, this looks at targets from the UN AIDS, and similarly, this is not dissimilar from the US AIDS response coming just this year. But you can see on the left in blue what the models, mathematical models, are remarkable things. You can put great assumptions in, and you can in epidemics on the computer screen. But that's not what we're here to do. But you can see that we were meant to reach 90% of all those key populations, key and vulnerable populations, with services. 90% of adolescent girls and young women in Africa. Reach over 6 billion condoms per year, 3 million people to be on PrEP, 5 million additional circumcisions per year in key African countries. And had we done all of that, in addition to reaching 90-90-90, and let's not forget doubling the financial resources globally, we would have been on this blue line and we would have reduced from 1.8 million new infections to 500,000 new infections. That's when we would have reached a point of beginning to get this epidemic under control. But we stand here on the precipice of 2020, and you can see what we've actually achieved, which is actually a fraction of what we need. And I don't want to be a downer here. That is, what we've achieved is remarkable. That 24 million people are on antiretroviral therapy is nothing short of remarkable. But it is not enough, because you can see that where we were meant to have fewer than 500,000 new infections each year, we still tragically sit with 1.7 million new infections every year. So in our report that we put out every year for 25 years now, this year's report we just called Now What? Because we sat and looked at all this and said, well, now what? And now what can be a question that makes you think we haven't achieved certain things, but now what can actually be quite a catalyzing moment. I hope that it is for everybody. We boiled it down to 3 things, and I would encourage each one of us to think, now what? Now that we stand on the shoulders of really remarkable giants in this field of activism and science, what do we do now? Our simple recipe of 3 things. We need bold, activist, visible leadership. From the grassroots to Geneva. We call out Geneva because, as you will know, just a month ago, there was a new head of UN AIDS. UN AIDS, the global institution that was meant to be a voice for advocacy and activism and progress, has actually been in a bit of a tailspin. So we look to activism in Geneva, we look to activism at the grassroots in every community in the United States and around the world to be bold and activist and visible in making demands. 2, we need to updates to the next generation of targets with evidence. Mathematical models are really helpful, but if we don't take what we have learned in the last 5 years and translate that into realistic targets for 2025 and 2030, we will stand here on World AIDS Day in 2030 and say we missed the targets again. Let us not do that. And third, I'll spend just a minute on what we mean by doubling down on multi-layered prevention. We spend a lot of our time at AVAC thinking about the 3 Ds: deliver, demonstrate, and develop. You know, very often we all want the one great thing to end this epidemic. And AVAC started as the AIDS Vaccine Advocacy Coalition 25 years ago. And we dropped the name itself and just call ourselves AVAC because it became very clear that an AIDS vaccine alone was not going to end this epidemic, and certainly not soon enough. A very simple red line shows the epidemic curve that we need. And what we try to do each year is to show what we have to deliver at scale with urgency, what we have to demonstrate in novel new approaches that are becoming real, and still develop long-term strategies like a vaccine and a cure. Take any one of those 3 colors away, we will not end this epidemic durably, sustainably, for good. We have to operate on all 3 levels at the same time. Just to give you a reason why I think there is so much reason to be excited right now is the research and development pipeline has never been more exciting. I won't take you through all of this, but remember that 10 years ago we had abstinence, fidelity, and condom use. We now have all of that plus PrEP and circumcision, and undetectable is untransmittable. That is not enough, but it is far more than we've ever had, and you can see on your right, my left, what is yet to come. Products that are in next generation development. We don't typically want to put timelines. Will we have a vaccine in 4 years, 5 years, 10 years? I don't know. But I know we are making solid advances. And the robust pipeline has never been more exciting for activists and for scientists. Just a snapshot of what's to come over the next couple of years. A vaginal ring could become a reality for women. We had the latest oral PrEP drug approved just for some people some of the time, an epic failure by the Food and Drug Administration and by Gilead Sciences to create a product that could only be available to some. This is an epidemic that needs to leave no one behind ever. And now there'll be another trial, too late, but as we often say, better late than never. A monthly pill that's got a lot of people excited coming from Merck that is still in early development phases. Long-acting injectables, antibodies, vaccines. I won't go through them all. I will say, standing here on the NIH campus, none of this would be possible without U.S. taxpayer dollars and without NIH leadership. Every one of these products, no matter what other philanthropy or companies involved, without the NIH, there is no pipeline. Research matters. It matters gravely. We wouldn't be able to talk about the end of the epidemic if it had not been for 38 years of science, and we won't end the epidemic if we don't sustain that research going forward. And just to say what is to come over the next couple of years, some very exciting things. I put in bold and underlined some things to really be attentive to. Just in the next year, we will find out for the first time if an antibody isolated here on the NIH campus might actually prevent HIV. It's also being looked at for treatment and for cure. We don't know what the result will be, but when we get that result, what will we do with it? Because the oral PrEP experience has taught us that developing a product is actually the easy part. Delivering it, making it real, having it have impact, that's the hard part. So every one of these icons represents a challenge, not just for product development, but for the next generation of delivery. And finally, I just want to end with this. We spend a lot of our time in biomedical science talking about products. Products don't end epidemics. People who have access to them, providers who make them available in compassionate, destigmatizing, caring ways. That's what ends epidemics. We often think about things as we look about products as products that people use, choose, and pay the dues. And very often those who use are not the ones that get to choose. It's often done by a provider or by a health system. And who's paying the dues? It's often not the individual, because health systems, whether in this country or in most other places where I work, health systems, for different reasons, are pretty abysmal in understanding those who use, those who choose, and those who pay the dues. So as we develop every one of our next generation products, whether it's a pill or a ring or an injection or a vaccine or an antibody, they will not deliver themselves. They will not magically get in people's bodies if we do not create the systems to more urgently and rapidly get them taken up. So at the end of the day, we have to ask ourselves, as we get excited by science, whether for treatment or for prevention or for cure, is where is the greatest unmet need? And how do we fill it with what people want and will use, not what the laboratory or the clinician can develop? How do we merge and bring together communities and product developers? How do we do that fastest and most ethically in a much more challenging universe? given that we are seeing incidence decline. That's going to make research harder. This is a high-quality problem, but a problem nonetheless that we've got to grapple with. And how do we deliver all of these products? And most of all, how do we balance the portfolio? Not something I do particularly well personally. I think you're supposed to do that once in a while if you are an investor. I am not. But how do we balance the portfolio? Not just of treatment and prevention and cure from a research perspective, but between science and systemic and structural issues, between people and products, between people and providers. How do we keep the right balance all along? I don't have answers to any of these questions, and no one does. But we will answer those together. And that really is, for me, where communities and the NIH and the scientific community need to come together. So thank you very much.
Thank you very much, Mitchell, for the palate cleanser and reality check. Next, I'd like to introduce Consuela Lopez, who is the former president of the board of Casa Ruby. Ms. Lopez's community work and activism includes coordinating programs for Latinx immigrant and refugee communities and the LGBTQ community. She's also an appointee to the D.C. Mayor's Office on LGBTQ affairs, both under Vincent Gray and Muriel Bowser, and served as a campaign representative for the Office of Human Rights, Transgender, and Gender Identity Campaign.
Thank you. And I just want to say thank you to NIH for having me come here to share my story. So I don't have any formal education, but I have a lot of life experiences being trans. Transitioning here in Washington, D.C. in 1992, seeing my friends go through their tribes and tribulations while transitioning. The way that I can relate to AIDS and HIV positive, my best friend who had the average life expectancy span of 31 at the time, passed away, and we were best friends since we were 15. I've had a lot of friends who died from AIDS, and I actually saw the epidemic when I transitioned in 1992, and I saw how people looked at people who had full-blown AIDS and the stigmas that it came along with it. It makes me feel sad that one of my very best friends at the time, who came to say goodbye to me, I was so scared because I didn't know how it was being transmitted at the time. And moving forward, that's how it got me into an activist. Ruby Corrado is the founder of Casa Ruby, and when she told me that she was opening up this center, I wanted to be there because I didn't know, as a trans woman, how to give back to my community. Because we're usually not in these spaces, we're usually not even allowed at these tables because of not culture of competency, but culture of humility. Because most of us have an eighth grade level education, not because we don't want to, just because of the lifestyle that comes along with just transitioning. It goes back into, transphobia. It goes into this circle of how come we end up doing survival sex work? Like, is there anything else for us? I tend to look at the very beginning of the whole pattern of what I saw is that I was raised in an era where you transitioned and you immediately had to go be a sex worker because no one would hire you during the day. You were definitely looked at as a sexual object, but not as an administrative assistant for an office. Then came, trainings, came programs and everything that addressed that trans women were normal and that we could actually do the job. And we went through this training period of trying to get the name of just being a sex worker and being trans, woman of color, and we tried to change that narrative. We tried to change the way people viewed us. And a whole bunch of us went through some training programs here in Washington, D.C. that were specifically for trans women. When we went through that process, literally, I would say about a 50 group, only 2 were hired, and those 2 were hired at churches. So we went through this cycle of trying to better ourselves, but we just kept going back to square one, back to square one. And knowing now more numbers like about from the community and how things work, this is an uncomfortable conversation, but I think it needs to be had because we talk about the growing rate of HIV, and I believe that trans women are at the highest number of the growing rate of people who are being infected with HIV. There's this other part that we don't talk about that I think it's important, that people sometimes see HIV as a savior, where if you live in a lower income community and you see somebody who's HIV positive and they have an apartment and they have like food stamps, it's much better than probably in their situation that they are in right now. So those things happen when you look at HIV not just as a death sentence anymore, you see it as a ticket to a better lifestyle. That's where Casa Ruby comes into play, where we have a lot of trans women of color, everybody, LGBTQ, and we come in and we address those issues. We talk to our siblings, our daughters, our nieces, our nephews, everybody, and we try to educate them on what the reality is of being HIV positive and what it could be. So I just want to say that sitting here in this room and having the opportunity to talk about what trans women face on a day-to-day basis, and it makes you understand why would our community choose such lifestyle, choose to be in a situation much better than they are, is because of what happens. I mean, statistics show the DC Office of Human Rights just did a campaign called Trans Resumes, where even if you are a transgender woman who has a resume, who has education, if you get sent out into the work field, you're still going to be you're not going to be hired, and someone's going to be hired with less education and cisgender. So we have these proofs, and we have all this documented data indicating how transgender women are being transgender women of color are being treated, and it needs to change. Until this cycle changes, I don't think that we're going to see trans women succeed as far as like not being put themselves in survival sex work. There's another number that I know that here in the DMV area, there was a transgender needs assessment done that 89% of transgender women of color in the DMV area are survivor sex workers. And the other 11% are honest tax-paying citizens. But I always say people think of the 89%, the big number. I say, look at who the customers are. Look at the people who are putting us in these situations, in these marginalized communities. It's the men. It's the hetero, masculine toxicity? The masculinity toxic, where just because we don't look like the normal women, or if you pass, or if you're pretty, or if you're lighter or whatever, then yeah, then you get the opportunity. But for the person who, let's say, has like the education but doesn't pass or isn't pretty in the daytime, then they're not going to give you the same opportunity. And then that puts you back into that survival sex work, because you got to eat. You need a place to, you have to have a place to lay your head. And they do have places like that for people who are ages 18 to 24, but as soon as you age out of the program, then you don't have anything. And you're fed to ride for yourself, particularly when your parents have thrown you away, you don't have any family that can help you. You just have your own sisters and your own brothers that you've built within your own community, your chosen family, and that's how we're able to learn from one another. And that's what Casa Ruby has done to a lot of trans women. Because something that's important as a trans woman, I sit here and I think and I look into the room and I just say, I can just relate to one person here that I know. Her name's Marissa. So think about that. Like, we come into a room and automatically you don't see people like yourself. In order for us to learn from each other, we have to see people like ourselves so I can trust her. So look around sometimes and think of how many trans people that work with you, trans people that go to school with you, trans people that are accepted and given the same opportunity. It's very far few in between. And The list can go on and on about all the disparities that we face, but trans women of color face the grunt and the violence and discrimination amongst everything. Thank you.
Thank you very much. So I know it's getting into the lunch hour, but please don't go away. We have 2 remaining speakers and then an open forum time at the end that will be led by Reverend Hickman. So without further ado, Mr. Daniel Driffin is an HIV activist and co-founder of Thrive SS, an online support system that builds networks around the country for Black, gay, and bisexual men living with HIV to help them achieve viral suppression and address other needs facing men of color. Thrive SS has hosted hundreds of events, forums, and meetings, and has addressed increased membership to 950 Black, gay, bisexual men and 230 Black women in the Atlanta metropolitan area. Thank you.
Good morning. As a child of the 90s, the greatest, I grew up reading The Magic School Bus and being educated by Miss Frizzo and Liz, the lizard. And I vividly remember taking a trip down the double helix axis of DNA. So to be standing with you all, like where science is cool for everyone, it gives me great pleasure to talk about one of my babies that I've birthed. So my name is Daniel, and this is a quick snapshot of me. My mom, my little sister, one of my mentors, Dr. David Malbranch. The day that I completed my master's in public health from Morehouse School of Medicine in Atlanta, Georgia. I love airplanes. I'm on the protocol team for the HIV Prevention Trial Network, 096, which is one of the few studies that will specifically look at how do we provide additional HIV testing in addition to linkage to care for Black men across many of the jurisdictions connected to the ending the HIV epidemic that is in protocol development right now. And also I serve on our Ryan White Part A Planning Council. So again, when we think about many of these intersections, this is who I am. I had the opportunity to create an organization with 2 colleagues, Dwayne Bridges and Larry Scott Walker, just by happenstance, because we did not see us in support systems across the Atlanta metropolitan. We had the opportunity to create an organization called Thrive, and it stands for Transforming HIV Resentment into Victory Everlasting Support Services. Say it one more time. Transforming HIV resentment into Victory Everlasting Support Services. So within our name itself, we are the HIV self-love campaign that we were waiting for. We started by happenstance back in March 2015. We said, hey, we're having a support group come out if you're interested, and 45 guys showed up by word of mouth. Today we have more than 950 connected to our services in Atlanta, Georgia, in addition to more than 245 women connected to a similar support group modeled off of our backbone called Heather IV. And these are some of the additional auxiliary groups that we have within our online support network, to include a mental health group that meets every Monday to talk about just what it's like living with HIV and thriving. We have a road tipping group that gives people living with HIV in and around Atlanta, just opportunities to go and see other things, in addition to some front-facing groups like our Political and Social Action Network. We have a community choir in the Thrive Toastmasters, which is an actual Toastmasters chapter. So the question, I live on Facebook, and I pose this question to some of my followers. So what do you think NIH needs to know about ending the HIV epidemic? And just like many of the speakers have said already, the answer is in community engagement. So ensuring that individuals who are most impacted by HIV are leading the process. Those people are developing implementing, and most importantly, evaluating what we're doing. That includes Black, Latinx, trans-identified individuals throughout the process, in addition to ensuring that investments, decision-making equal partners throughout the entire process. The plan. The plan has to be, number one, it has to be rooted in communication, and secondly, community and culture. Again, cultural humility, not just cultural competency, but cultural humility. We have to ensure that we are asking the question of whether or not the system can improve in itself. And that should always be a yes. The system, our systems that we are delivering and providing services to Black and brown people across the nation and across the world should always be in the place to improve itself. So what has cultural and community provided or created at Thrive Support Services? This is a snapshot of the Silver Lining Project. We don't believe in calling folks old. We believe in calling them seasoned. So some of our seasoned brothers above the age of 50 put their heads together and they created the Silver Lining Project. It is a project for men above the age of 50 to participate back in HIV services and care. They ultimately put their heads together and wrote a HIV agent grant to a pharmaceutical company, and they received more than $500,000 to program over the next 5 years. These are some of the pictures that have came out of the Silver Lining Project, and they have a campaign called I Swallow. And that is how they survive. That's how they thrive, by swallowing their daily ARVs. In addition to some of our other I Thrive campaigns listed on the screen. And you can take a snapshot of the QR code, and that will take you to more than 150 photos created by people living with HIV, showing how they thrive every day of the week. So I'm a nerd, and I wanted to create something to show exactly where brothers and sisters connected to the Thrive services were falling. And we created an engagement survey. So we modeled it on the premise of the HIV care continuum. So when you were diagnosed to ultimately achieving viral suppression. We usually open our survey for about 3 months. The first year we did it was back in 2015, and we showed roughly 80% of the individuals who completed the survey were undetectable. As we continued to program more and program from a more intentional place, providing like daily adherence reminders in the form of pill checks, our 2018 surveys showed that 92% of those individuals who took our survey were virally suppressed. And this was a sample size of about 450 of the 700 folks at the time. So again, it showed us that folks like Black gay men specifically value their health and they want to be engaged, okay? This was one of those other out-of-the-box conversations that we were having one night on Facebook, because many places you could not get HIV tested or even STI testing after the hours of 4:31 p.m. on a Friday. So we came to the table and we created something called The Spot. And we provided HIV, STI, and other linkage of services to our community in non-traditional ways. So, of course, we're open Monday through Friday, 10 to 5, but on the weekends, we have nighttime hours. That includes 7 p.m. to midnight, 7 p.m. to 2 a.m., and that Sunday fun day after brunch, 3 to 6. Over the past year, we provided testing to more than 100 people connected to the Spot services, but we connected more than 27 Black gay men back to care who have fallen out of care at some point in time, either from moving to Atlanta or just where we call them disservice providers, just do not continue the follow-up that is necessary. These are some of our photo campaigns. Again, we use rich pictures, but we come from the place of everything that's in that black box. Meaningful involvement of people with HIV, meaningful involvement with gay men, trans sisters, trans brothers. We use a harm reduction approach. We are sex positive, cultural humility. We use health literacy, so ensuring that we do not speak in more than 5-syllable words. Because again, if you can deliver it simply, do it. We provide Lyft rides, Uber rides, and we're client-centered. So this is really what it looks like. R3, how do we do this? It's coming to the standpoint of re-engagement regardless of anything. So this brother sent us a message back in October, and he was saying, after 8 years of not treatment, he was feeling his body change and he was ready to get into care. We connected him to care within 24 hours at one of the organizations, and then he uploaded this about 2 months later, and it just demonstrates, number one, how quickly one can get undetectable, but also it demonstrates the power of social support. More than 200 people liked this message inside of our closed group, and he's now in one of our campaigns. So the takeaways. If you watch Bird Box on Netflix, this is the picture from that. It's here to say Black gay men, Black MSM, transgender identified women, trans men are not hard to find. We're not hard to find. Let me say it one more time. We're not hard to find. We will be found as if you're using meaningful collaboration of us. Again, leading, developing, implementing, evaluating. Listen, listen, listen. Listen not to just respond, but listen to change the game. Reimagine and rethink everything. And I think this is additionally where NIH comes in. C grants. I think the opportunity to have some type of a system like we have your R awards, your K awards, your T awards for community organizations demonstrating the reach and need into specialized populations, in addition to pipeline leadership. I managed an R01 with that was funded through NIMH between 2010 and 2015. It spurred me to go back to school to complete my MPH. And now I'm realizing, okay, let's just go all the way and do a DRPH so I could become a principal investigator to ensure that my community is moving along. So pipeline leadership is important. In closing, I wanted to start an organization to save my life. If whales, snails, dogs, cats, Chrysler, and Nixon can be saved, the lives of Black men are priceless and can be saved. These words are from one of our great patron saints, Essex Hemphill, who was also a person living with AIDS at the time. So again, I just thank you for the opportunity to come and deliver a little piece of what's going on in my hood every day of the week. Thank you.
Thank you, Daniel, for cementing home that message about the importance of client-centered services, cultural humility, competence, and collaborative participatory research. Ms. Abby Charles is our last speaker and is a senior program manager at the Institute for Public Health Innovation, providing leadership and coordination for the community health worker initiatives, overseeing a network of community health workers and a portfolio of programs in which IPHI addresses cross-jurisdictional policymaking and information sharing, program refinement, policy research training, implementation, evaluation, and technical assistance.
Thanks. Yeah, I have a short amount of time, and we're really close to 1 p.m., but, I'm sitting here and I'm just reflecting on what an honor it is to speak on behalf of the workforce that is really driving change as it relates to the HIV epidemic, community health workers, peers, and I think we've heard it from a number of speakers today, the importance of people living with HIV as they have been the glue from the community to the clinic in this epidemic. Yet still, when it comes to the workforce and when people living with HIV walk into health systems, they are not met by people who look like them. When grants end, the first position to be cut is often that peer position, is often that community health worker position. And we have to be really thoughtful about what that means as it relates to sustainability of care. treatment adherence, and retention. But we also have to think about what does that mean as we think about Mitchell's slide that has all these great things that are in the pipeline. And I'll ask you a question. If a tree falls in the forest, does anybody hear it? If we don't have the workforce that looks like our community to get the messages of change, messages of treatment, messages of prep into the hands in that culturally humble way, we're going to continue to see significant inequities as it relates to HIV. So, my hope is that I get to talk about, and I was asked very specifically to talk about the community health worker role in transforming HIV in our communities. So I hope I speak to that, and as well talk a little bit about how we can work to sustain this workforce across our health system. Our health system is changing significantly. Community-based organizations are going out of business because funding is changing. And we have to think about how do we integrate payers into a workforce that looks increasingly like large health systems, right? So I work for the Institute for Public Health Innovation. We are the Public Health Institute for DC, Maryland, and Virginia. There are about 40 public health institutes nationally, and we fall under the National Network of Public Health Institutes. But at IPHI, we have the Center for the Community Health Workforce, and we work on regionally ensuring that the community health worker workforce is sustained. So we work with the different health departments in DC, Maryland, and Virginia to support policy for community health worker sustainability, as well as, we do training for community health workers. We're working on identifying best practices as it relates to program development, et cetera, with community health workers. And our work in this started with a project called Positive Pathways, which was funded by the Access to Care initiative that came out of the Corporation for Community Service under Obama's administration. That was funded by AIDS United, and we worked in partnership with Washington AIDS Partnership here in DC to build a program that integrated community health workers across 7 different settings: community-based organizations, managed care organizations, clinics, hospitals. When we were building the project, we were talking to sites, and what they said was, what we need payers, but we need payers to be paid. We need payers to be paid well. We need payers to be trained, because what we were seeing is that each organization had people working in different ways, and there was very little standardization of training for community health workers or these payers. So we built a standard training model. We integrated and worked with the Community Health Worker Association in the District of Columbia at that time to ensure that the pairs we were training were integrated into any certification efforts that were happening in the city. And as we built out that model, what we learned was that, DC, we had in the District of Columbia extremely high insurance coverage. So we knew that access to HIV care wasn't tied to access to insurance. Access to HIV care was tied to the many social factors that affect people's access to health: housing, transportation, food. And the community health workers, the people who were from these neighborhoods, knew better than anyone else how to get to the people. And we were enrolling persons who they had fallen out of care, and in general, they were diagnosed for more than 10 years and had fallen out of care, were tired, lived with multiple comorbidities, and faced many, many social factors that were keeping them out of health care, right? So these CHWs were able to get people back in care that nobody else could, right? They were able to knock on doors, walk into those neighborhoods, and get people in. So critical, so important. After 5 years, of course, the funding ended, but we were able to work with the DC Department of Health to ensure that the sites that the CHWs were placed at, we used EIS funding and found creative ways to use Ryan White to ensure that peers were integrated into our systems. And we found that as a result of that project and the outcomes, people who were enrolled in the project had their social needs decline, and their viral loads decline, and their CD4 counts improve. So because of that data, we were able to get the health department to say, we need CHWs. So, DC's 1990 plan integrates CHWs into it. In the same way, in the Virginia Department of Health at VDH, our HIV funding, almost every application includes CHWs, pairs, as critical members of the healthcare workforce. But nationally, that's not the case. CHWs are not sustained and are not sustainable. So who are these community health workers? I've been saying this word a lot, but community health workers are frontline public health workers who are trusted members of and or have an unusually close understanding of the community served. They're from these neighborhoods, they're living with these diseases, and as such, they're able to build that trusting relationship that we've heard about. And it enables these workers to serve as liaisons, links, intermediaries between the health services and the community to facilitate access to services in a very unique way, and to ensure that we're improving the quality and cultural competence of service delivery. There are many different titles. So every community health worker we've trained had no idea they were a community health worker when they came into the room. None. They're promotoras, they're peer advocates, they're peer leaders, they're health coaches, they're outreach workers, they're outreach advocates, but we were very strategic about using the word community health worker because CHWs are listed in the Affordable Care Act, right? Community health workers are that workforce job description that the Department of Labor uses. So we want to be very intentional and strategic as we think about, as we sustain or ensure that peers are integrated into the workforce. And this is important for multiple reasons. One, they're the ones who are going to get people who are at risk and living with HIV into services. But also, this is workforce development for many people living with HIV, right? This is economic enhancement. And we must ensure that we are creating pipelines into healthcare for our communities. Change is happening nationally, right? CHW certification is happening across the country. There are many states that have passed certification. Maryland has passed certification. CHW started being certified last month. Virginia has a grandparenting program and will start official new certification of CHWs in April next year. DC is moving forward with legislation. So as we think about how do we expand our health workforce, how do we connect to these certification efforts across this country? And I'm going to get to why that's important for research too in a little bit, but we want to make sure that we have CHWs integrated into our research teams as well. So my question, sustainability, right? So financing is one of the biggest pieces that's a challenge, and we're seeing that Medicaid nationally is moving more and more so to value-based payments. We need more studies that show the importance of CHWs on care teams here. As I'm reaching out to hospitals in these regions, they're saying, yeah, we know that that was evidence over there, but what evidence do we have that this works here, right? So we need more research to prove to the payers that CHWs are the workforce of the future, right? Our health systems have to begin employing these CHWs just as they employ nurses. And it behooves us, we are behooved to ensure that CHWs are trained on all topics related to HIV, and that our payers who are experts in HIV are trained as CHWs and are integrated into our health system so that anybody who touches the health system is getting the information that they need on PrEP, on HIV treatment, on prevention, on testing. It's critical, right? As researchers, we want to understand the CHW workforces in the region that you work in. Where do community health workers exist? What communities do they work with? What work do they perform? As we think about training, right, so we're standardizing training for community health workers and payers nationally. That's what certification means. How do we ensure that HIV is integrated as one of those topics for certification? So for example, in Virginia, anyone who's trained as a CHW, HIV is a core training topic. So you must have HIV education as a core if you are going to be a CHW in Virginia. That's not the same in many other states. So we need to be at that table and ensuring that that's valued. But we also need to research and figure out what is the training that peers need to be the most effective. Invite CHW networks to your meetings, to your conferences, to be on your community advisory boards. And like I said, integrate HIV training into your certification efforts. And cross-train CHWs working in other health and social service areas, because there are many. There are CHWs working on opioids. There are CHWs working on maternal and child health issues. How do we ensure that HIV is integrated into all of that work? That's the only way we're going to really get the message out and ensure that those trees are heard in the forest. Partnerships are key. You know, we have a CHW who worked really closely with an NIH staffer, and anytime someone needed some social services, he would get a call, and anytime we met someone who was eligible for a study, that CHW would refer them back to that person. Make sure that you're building relationships, strong, key relationships with organizations that integrate community health workers into their work. Refer and ensure that CHWs are paid living wages, right? So on your research teams, if you have community health workers, not only as they are working directly with patients on treatment adherence, ensure that they're paid, and ensure that they're paid really well, living wages, but also integrate CHWs so that we are better educating our communities, the ones who are still scarred from Tuskegee, about why research is important, right? CHWs are so valuable. And as we need to increase the diversity of our studies, we're going to need to increase the diversity of our teams and our staff. CHWs are that person. And I'm going to read just one last quote as I close. But this comes from a 2004 study titled Missing Persons, right? Minorities in the health professions. And we know that although this country is going to be a majority minority country by an estimate show about 2043 to 2045, we only have 9.2% of minorities in healthcare professions. That's real. That has to change, right? In order to do that, we're going to have to increase our workforce. It starts with community health workers. That is not by any means the entire solution. But in order to increase that cultural humility of our health systems, we're going to need that workforce. But this quote says that the fact that the nation's health professions have not kept pace with changing demographics may be an even greater cause of disparities in health access and outcomes than the persistent lack of health insurance for millions of Americans. That's changed a bit. Today's physicians, nurses, and dentists have too little resemblance to the diverse populations they serve, leaving many Americans feeling excluded by a system that seems distant and uncaring. And we heard it today. Question, who is in the room? As you're building our studies, as we're thinking about this disease, who is in the room? Who's not in the room? And how do we ensure that our workforce continues to reflect the people who are most affected by HIV? Thank you very much.
Thank you so much, Abby, for the importance highlighting the importance of peers and the critical role of the workforce that looks like the clients they serve and knows the community. And one more round, please, for our speakers. And we're fantastic session. And I'd like to invite Reverend Hickman down to the table. I'm not sure, are we asking all the speakers who are still here to come, or is it part of an open forum? For the remaining time we have, any questions and comments from people in the audience? Thank you. Okay.
So we have approximately 7 minutes to close. And the overall purpose of this open forum is to be informational, and no commitments are to be made or expected at this point in time, but it is an opening few moments of listening, and we ask that you be concise and precise and do your comments in less than 30 seconds. And I'll start with the panelists, just one or two of you, if you can answer the question, which I think most of you already have answered the questions of what does your organization envision as the greatest need for further community engagement?
I'll jump in.
Okay.
I think organizations, especially organizations like mine, need, the buy-in support from entities like NIH, like CDC, like any of your federal partners. I think to truly buy into grassroots organizations that are touching the most impacted communities, and then validating those same those same organizations through, the gold standard of studies, through publications, et cetera, et cetera. I think that's truly what I haven't seen enough of, especially in the time that we've been operating thus far.
Okay. Marissa, did you have your hand up? Marissa?
I will answer. I did not have my hand up. I think intentional inclusion of trans, non-binary, and gender non-conforming people to be a part of what programming looks like, to be a part of what healing looks like for institutional harm. I think sometimes we, as I said, I'm certainly grateful for the opportunity to have been able to start out as an outreach worker, but that was not where my career ended. And so had I not had individuals that took on leadership development with me, I probably still would have been an outreach worker. So I think there's an intentional investment that we have to challenge the trans, non-binary, and gender non-conforming populations to be involved, directly involved in the narrative. And while I agree that part of ending the epidemic would be involving community health workers, I don't want us to stop there. I don't want us to just stop at peer educators, linkage to care specialists, because equity means a lot. And we're talking about changing systemic harm and changing how systems work. I think that you have to include trans people in leadership. Mm-hmm. You have to include trans people at tables where decisions are not distributed, but where decisions are formulated and made. And I think it has to be more of an intentional involvement and not in a tokenizing manner. You can't just hire one of us.
Amen.
You have to hire a community, and I'm not saying that you have to hire people that are not qualified. There are qualified trans, non-binary, and gender non-conforming people that are out there, We have doctorally trained nurses, we have lawyers, and we have doctors, and we have those people that are grant writers and banks, and so we don't want to just keep talking about, and one of the other things I think that as we move forward.
I'm going to have to ask you to.
The last thing is, as we move forward, stop using stigmatizing pictures of trans individuals when just talking about sex work. Showcase us at our best, not always at our work. And sex work is real work.
We're going to have to ask Dr. Goodnow to bring us all back. We have lots to say. Thank you very much, Marissa. I so appreciate you. And the next question is, how has the ending the HIV epidemic affected our organizations? At any point in time, any of you can answer, or maybe someone in the audience would like to answer.
Well, it started out with distrust, first of all, because we said that we were going to involve community-based organizations at the root of applying for 1904, 1906? Whichever number it is, 06, we said that we were going to start with community-based organizations. Then we ran out of time, so we went to the state health departments. I rushed around Washington, D.C. to put together the 50 jurisdictions to have that conversation. I think that we have to do what we say, and if things change that prevent us from doing what we say, we do owe community an explanation of why things have changed.
Guillermo.
Yes, thank you. I will only add that it's essential that this effort at the federal level trickle down at the city, county, and state level, and territories. And I think it's an opportunity for communities to engage. This right now, the effort is going to be led by health departments, but we know that without community, we will be setting ourselves for failure. And I think engagement requires not only, to build a workforce that will reflect the communities that we serve, but also to understand that we must be part of this transformation. And I think we need to do an effort to train people how to engage the city, county, and state health departments and the federal agencies under HHS family that truly we develop a plan that will truly take us to the goals of 2030 and beyond, reaching vaccine and cure. Thank you.
And I would like to say, since we are just about out of time and Dr. Goodnow is going to come and bring us closing remarks, everyone has been stellar today, and I really want to say thank you, Dr. Goodnow, to you and all of your staff for being phenomenal and having such a group of panelists here that we need more time. However, I want to leave us with a thought and an action. I want us to go back and read Audre Lorde's poem on the master's tools, because I think that what we're talking about is that we can't use the master's tools to mantle up what we need to build today. but we do need to pay attention to how different we are from yesterday and how we are in today. And we need to use tools that will dismantle the master's house and build the master's house. Thank you.
Well, I know the hour is late, and I really appreciate everyone who has been part of this from since 10 o'clock this morning. Thank you very much to our panelists. I can't tell you what a moving day this has been, and the richness of your comments. We're hearing them and we've heard them. For reference, the video from today's proceedings will be archived online for those who want to review it or to see it for the first time. There's going to be a link to the video on the OAR website, and one of the things that I'm committing is that we will be putting together a summary report, an executive summary of this, and include some of the action items that we heard today. So thank you again, and please realize that this is not a one and done. We see this as the beginning, a continuation of conversations that we've started before, new conversations that started today, but definitely to continue the communication and the engagement with you as our partners. So thank you very much, all of you, and thanks to the audience.